So we are going to continue by talking about the protozoa. But before I start, I need to show some questions on bacteriology before we proceed. So this is a 27-year-old man who comes to the physician with throbbing right scrotal pain for 1 day. He has also a burning sensation on urination during the past 4 days. He's sexually active with multiple female partners and does not use condoms. Physical examination shows a tender, palpable swelling on the upper pole of the right testicle. Lifting the testicle relieves the pain. A gram stain of the urethral secretion shows numerous polymononuclear leukocytes but no organisms. Which of the following is the most likely causal organism of this patient's symptoms? Anybody?
Chlamydia trachomatis.
Chlamydia trachomatis.
So why are we picking Chlamydia trachomatis?
The patient is 27 years old and
Okay.
there is some positive French test. So you're able to differentiate between epididymitis and torsion. So this patient has epididymitis and there are two organisms that are complicated, chlamydia and gonorrhea. And they said that there is no organism, so it will be chlamydia.
That's very good. Very good analysis. Well done. For this, after being admitted to the hospital for widespread second-degree burn injury on his arms and thorax, a 29-year-old man develops a fever and wound discharge. His temperature is 38.8. Examination shows a discolored burn eschar with edema and redness of the surrounding skin. The wounds have a sickly, sweet odor. A culture of the affected tissue grows an anaerobic gram-negative rot. The causal organism most likely produced which of the following substance? This one is deep.
Let's see.
I know it's Pseudomonas.
Yeah,
Okay.
Pseudomonas.
So why is this Pseudomonas? Why is this Pseudomonas?
It's a common
Bacillus
nosocomial infection that is common in burns patients.
Very good.
And this patient had a second-degree burn.
Okay.
So, and then it also said it had a sweet odor.
Yes.
And that's another reason why I think it's Pseudomonas.
So I agree. So, but which toxin do we think is particular to Pseudomonas here?
Phospholipase C.
That's nice. Don't forget the PEEP. Phospholipase C. That's very correct.
Okay.
The PEEP for Pseudomonas. The P standing for the phospholipase C, which helps to break down the cell membranes. You know, that's the reason why this person is having like a wound, breakdown or injury, wound discharge and likes, because of the phospholipase C that is lysing the cell membranes of the cells within the wound. And the E is talking about the endotoxin. The next E is talking about the exotoxin that they produce, exotoxin. And the P, the last P is talking about the pyocyanin and the pyovadin that they release. So those things are peculiar to Pseudomonas. So we should not forget that.
Dr. Babawale, I thought phospholipase is Clostridium perfringens.
No, phospholipase. Yes, but this is phospholipase C. So that of Clostridium perfringens is also a phospholipase. It can also be a lecithinase. All of them, they are together. But the toxin is actually named the alpha toxin. So, but that alpha toxin has like this, what's it called, phospholipase or lecithinase activity. Is that Dr. Nancy?
Yes. How are you?
So you are correct. The toxin has phospholipase activity, but this one is not actually talking about paphyringes. So, and the toxin produced, one of the toxin produced by Pseudomonas is the phospholipase C, enzyme. So, okay, I think I still have more. Um, A 13-year-old boy is brought to the emergency department by his mother because of 6-hour history of severe high pain and blurry vision. He wears soft contact lenses and has not removed them for 2 days. Ophthalmologic examination shows a deep corneal ulcer with severe conjunctival injection and purulent discharge on the right. Treatment with topical ciprofloxacin is initiated, and a culture of the ocular discharge is most likely to show the following. So, what are the diagnoses?
Pseudomonas.
Pseudomonas.
Keratitis.
So, if this is Pseudomonas, which one are we picking?
Gram-negative.
Gram-negative
Gram-negative,
oxygen
positive, vascular.
Okay, that's very correct.
Yeah,
That's very correct. What would this be?
That would be group A.
That's good. That would be group A. What would this be?
That would be syphilis.
That would be syphilis.
Treponema pallidum.
That is syphilis. That is syphilis. Very correct. What's this? Anybody?
That would be
Gonorrhea.
Gonorrhea.
Sorry, Neisseria
Gonorrhea.
meningitis.
Gonorrhea
Gonorrhea is normal.
It's gonorrhea.
It's gonorrhea. So if I change it to this, what will it be now?
Yeah, break
It will be
It's maltose.
it will be maltose, it will be meningitis.
So I have deleted the non. I have made it maltose fermenting. So it becomes meningitis. So do I still have more? Okay, I have one more. A 10-year-old girl is brought to the emergency department because of 2-day history of bloody diarrhea and abdominal pain. 4 days ago, she visited a petting zoo with her family. Her temperature is 39.4. Abdominal examination shows tenderness to palpation of the right lower quadrant. Stool cultures at 42 degrees Celsius grows colonies that turn black after adding phenylethylamine. Which of the following best describe the most likely causal organism? Anybody knows the causal organism? The clincher is very plenty. A 10-year-old girl, number 1. Bloody diarrhea, number 2. Visiting the zoo, number 3. She has stool cultures at 42 degrees Celsius, growing colonies, number 4. This is spot diagnosis. We've talked about it. A young child having bloody diarrhea. Anybody? Oh, network. I said, this is a 10-year-old girl that was brought to the emergency department because of 2-day history of bloody diarrhea and abdominal pain. 4 days ago, she visited a petting zoo with her family, and the temperature is 39.4. Abdominal examination shows tenderness to palpation of the right lower quadrant. Stool cultures at 42 degrees Celsius grows colony that turn black after adding phenylethylamine. Which of the following describes the most likely causal organism?
Is it a CGG?
What's CGG? Okay, say it. Say, I want to be sure. I don't want to assume.
Yeah, that one. The word that you were about to say,
Campylobacter.
Yeah,
Yes, that
this
one.
is Campylobacter.
Campylobacter.
So why are we saying it's Campylobacter?
It grows at 42 degrees.
Yes. What else?
On
With the bloody diarrhea.
Bloody diarrhea. What else?
Yes.
Which age group? A young.
Kids.
Children.
Children.
What else? What else? I think there's something else again. Okay, I think those are the common stuff, but we also have palpation at the right lower quadrant. So that's like due to the mesenteric adenitis and the terminal alitis that they develop. So, it's also in keeping with Campylobacter jejuni, and we can see the risk factor. She visited the petting zoo. Can we hear me?
Yes, sir.
Okay. So what is which one describes the morphology? Which option?
It's rod. But it has pump fruits.
So let's start this way. Is it a gram positive or gram negative?
It's
Gram
gram
negative.
negative.
It's gram negative. So it means all these gram
Negative.
positive, all these gram positive are out. So that means that we are left with 1 A, B, and D. Okay.
Mm-hmm.
Do we think it's flagellated or not?
It's flagellated.
It's
It's flagellated.
flagellated.
It's flagellated.
Mm-hmm.
So does it
Yes.
ferment glucose or lactose or not?
No, it does not.
It
It
does
does
not.
not.
It does not.
Lactose.
So that means
It
that the
does
answer
not.
is
So
B.
B.
So that is it. Sorry, it should
Yeah.
be
I think it's B.
it should be D.
Yes.
But
Yes.
Gram
But do not
negative,
ferment lactose.
flagellated,
D.
that does not
Mm-hmm.
ferment
Ferment
lactose.
lactose.
Okay. So that's the way to just look at all those things. Very simple. So we are starting with the protozoa. Giardia lamblia is the first on the list, and Giardia lamblia causes giardiasis. So giardiasis is very easy to identify. What you are just looking for is just a patient presenting with a foul-smelling, bulky diarrhea. Once they tell you that somebody is having fever and having at the same time a foul-smelling, bulky diarrhea or steatorrhea, just think about giardiasis as a possibility. So it's part of the causes of traveler's diarrhea, just like the enterotoxigenic E. coli. So they can say that the person is traveling from one area to another area, and after some days start developing foul-smelling, bulky diarrhea that is difficult to flush, or the patient is having flatulence and bloating. Just know that is giardiasis until otherwise proven. And how is it transmitted? By consumption of the cyst of this giardia's organism in contaminated water. And the way you make the diagnosis is identification of multinucleate trophozoite or the cyst in the stool. So we don't have the image for that. Okay, yeah. So these are the trophozoites. These are the trophozoites of the giardiasis. These are what they look like, and they are multinucleated. And how do you treat? You treat by using TNM staging. So you treat by using any one of the TNM. Any one of the TNMs you can be given. So you can give your tinidazole. You can use your nitazoxanide, nitazoxanide, and metronidazole. So tinidazole, metronidazole, they are like the same family. Then we have the nitazoxanide. So TNM for giardiasis. Just remember fat, house-smelling, bulky diarrhea that is fatty, and it is non-bloody. Please, we know the causes of bloody diarrhea. Giardiasis is not part of it. So moving on to Enteroamoeba histolytica. Very common. You can get this in your exam. It's high yield. You have to know amoebasis, it is high yield. They can ask you. And unlike giardiasis, Entamoeba histolytica is a cause of bloody diarrhea. It is a cause of dysentery. Why? Because this guy actually invades the intestine, particularly the colon. So it invades them. It even makes some ulcers. It forms some ulcers, in the colon. So if you do your histology, you can see some of the ulcers, which is flax shape. So you just see something looking like this. Exactly. So you see something looking like this, you can see this. This is a flax shape ulcer as you see on histology. Once you see this on histology, until otherwise proven, your answer is going to be Entamoeba histolytica. And of course, the diarrhea is going to be bloody. You cannot forget that. They are going to be having signs and symptoms of malabsorption, bloody diarrhea, and sometimes some of them can go to the tissues. So they can leave the intestine and form a cyst in the tissues, forming a liver abscess. So they are described as the Anchovy paste exudate. So don't worry yourself about the big name. Just know that Entamoeba histolytica can insist in the liver, forming a liver abscess, and it can cause intestinal infection leading to bloody diarrhea. And you can make the diagnosis by looking out for either you do serology, which is very common for almost all of them. You can do your antigen test, your PCR analysis. Don't worry about this, but pay attention to the fact that they can have an hematophagocytic trophozoite. So you notice that the trophozoites are engulfing red cells. So These are the hematophagocytic trophozoite, and they can have multinucleated cysts at the same time, cysts with like 4 nuclei. So this is an example of a cyst you see in entamoeba histolytica. And how do you treat? You cannot forget metronidazole. The mainstay to treat somebody that has entamoeba histolytical infection is to give the person metronidazole. They can ask you in your exam, when do you now give this paromomycin? So there's paromomycin, there's another one, there's iodoquinol. So it's iodoquinol, and there's paromomycin, iodoquinol, and paromomycin. So these ones, they are given to eliminate the intraluminal cyst, because this entamoeba histolytica, we have some forms that will go to the liver and insist in that area, forming the liver abscess. So we can give our metronidazole to help us eradicate some of those tissue forms of the entamoeba histolytica, like the one in the abscess and the liver, and maybe the colon too. But the iodoquinone and the paromomycin typically helps to limit the intraluminal cyst of this entamoeba histolytica, so that you reduce the shedding in fecal matter. So in that way, you also reduce the transmission of this entamoeba histolytica. So they can ask in your exam, like, which one do you use to reduce the intraluminal load of this entamoeba histolytica? So you are not going to pick metro, but you are going to pick either paromomycin or iodoquinone. But if somebody has a liver abscess, you must give your metronidazole. So cryptosporidium. Cryptosporidium is not a very serious organism. It doesn't cause much problem in people that are healthy, but it is a pain in the ass for people that are immunocompromised. So in people that are immunocompetent, just like Listeria, they can cause a self-limiting watery diarrhea. That is all. Please pay attention to the word watery diarrhea. Cryptosporidium, watery diarrhea. We did not say bloody diarrhea. So we should be able to delineate all those things. For anybody with HIV/AIDS, cryptosporidium is a big problem for them, particularly people that have a CD4 count less than 100. Then they start entertaining infections from organisms such as cryptosporidium. It causes severe diarrhea in them, and you might need to add medication for them. But an individual that has watery diarrhea and the person is immunocompetent, you don't need to do anything. Just make sure that you are filtering your water to reduce the oocyst of this cryptosporidium in the water. But if somebody is immunocompromised, or the person has a very severe form of infection, for whatever reason, from this cryptosporidium, you have to give nitazoxanide. So don't forget, that is exactly what you had in the TNM here, nitazoxanide. It also works for cryptosporidium. So you can see that because cryptosporidium is one of the acid-fast organisms, so you can stain the oocyst. We can see that this stain looks exactly like the what? Which stain is this? Anybody remembers?
Is it the Xenexin stain?
Yeah, this is a xenescent stain. You can see the blue background that we usually talk about, which contains the counter stain of the methylene blue. And we can see the purple carbon-fuchsin stain. So very important. We can see the oocyst being highlighted. So moving on to Toxoplasma gondii. Toxoplasma gondii is very interesting. Get it a lot in your exam. And the first thing I'm going to say is that Toxoplasma gondii is also not a problem in people that are immunocompetent. If somebody is immunocompetent and somebody get exposed to a cyst or oocyst containing this Toxoplasma gondii infection, the person might not develop problems. They can just have a mild mononucleosis-like symptoms. And when we say somebody has mild mononucleosis-like symptoms, it means that the person just have maybe headache, they have sore throat, they can have some lymphadenopathy in the neck, they can have maybe mild swelling of the liver and the spleen. Something that looks like infectious mononucleosis that we're going to talk about shortly. So don't worry about it. But once you are saying that, you are saying the fever, you are saying the sore throat, you are saying the cervical lymphadenopathy, hepatosplenomegaly, and you are thinking, is this a possibility of infectious mononucleosis? Then you want to go ahead by doing your heterophile antibody test, which I'm going to talk about. But this heterophile antibody test is going to be negative in them. So that's how you know that, oh, this is actually from mononucleosis-like infection. Either it's coming from CMV or it's coming from Toxoplasma, but it is not coming from EBV, because the major cause of infectious mononucleosis is what? Epstein-Barr virus. But if you see features of infectious mononucleosis and you do your heterophile antibody test and it is negative, the next option to consider is CMV. If you don't see CMV there, just pick Toxoplasma gondii. But for people that are immunosuppressed, they can have reactivation of this Toxoplasma gondii infection, which has insisted in the body. It can reactivate and can cause serious problem. And one of that problem is what? Presence of brain abscess. And what are we going to see on the CT or the MRI? We are going to be seeing multiple brain-enhancing lesions. So you see a patient, a 40-year-old man with HIV, CD4 count less than 100, having multiple brain abscess, multiple ring-enhancing lesion on MRI. Your diagnosis is going to be Toxoplasma gondii until otherwise proven. So you have to have that high index of suspicion. So how is it transmitted? So people that consume the cyst in the meat could be beef, it could be pork, it could be anything, it could be cat meat. People that eat cat, people that eat dog, cyst in the meat, yeah, and probably the animal has eaten this Toxoplasma gondii, so the animal is going to be having the cyst of the Toxoplasma gondii in its muscles. I remember that human beings eat muscles of animals. That's meat. That's what we call meat. So, or anybody that gets in contact with the litters of the cats. So people that get exposed to the fecal matter of the cats, they can also develop this Toxoplasma gondii, and in that way it can infect pregnant women, and pregnant women can also spread it vertically across the placenta to their baby. So it's very, very important that pregnant women avoid contact with cats, and also they should also avoid eating uncooked meat. So how do you make diagnosis? You can do serology, you can do biopsy. This is not going to be tested, but where they will wait for you is ability to identify this on imaging, ability to know the risk factors for the transmission, and ability to know the treatment and to know the prophylaxis. Now, I want to emphasize something here. Many people make this mistake, and I want us to pay serious attention here. The treatment for Toxoplasma gondii is sulfadiazine pyrimethamine. Sulfadiazine pyrimethamine, SP. The prophylaxis, if somebody is having CD4 count less than 100, is not sulfadiazine pyrimethamine but Septrin. So many people make the mistake of saying that treatment is Septrin, prophylaxis is Septrin. No. The treatment is sulfadiazine pyrimethamine, while the prophylaxis is what? Septrin. The trimethoprim, sulfamethoxazole. Very, very important. So we have a jotter somewhere, please scribble it in your jotter. And you give the prophylaxis when the CD4 count is less than 100. Now, where else are they going to wait for us? The diagnosis of congenital toxoplasmosis. And what are you looking for? All you are looking for is chin. All you are looking for is chin. 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 The C standing for the chorioretinitis. So they will tell us that probably the mother has some infectious mononucleosis-like symptoms, and later the baby start developing chorioretinitis after being born with hydrocephalus with ADH and intracranial calcification. Now, they might not put that there's intracranial calcification, but they might say that the calcification is diffuse. Once you see diffuse brain calcification, hydrocephalus, chorioretinitis, your diagnosis is going to be Toxoplasma gondii until otherwise proven. So, moving on to so these are the ones that have the ability to form CNS infection. Toxoplasma gondii. Another one is Naegleria fowleri. Very simple stuff. Naegleria fowleri. You don't need to bother yourself. All what you are looking for with respect to Naegleria fowleri is just the presence of amoeba. This guy is an amoeba. So if they have said their long story, 50-year-old man comes to this, just that, having this, having that, and they did the CSF analysis and they saw amoeba, you just smile and go and pick your Naegleria fowleri. Now, this guy can cause a rapidly fatal meningoencephalitis. Most people that have this, they die. They die. They don't. Most of the time they will die. It's just like CJD. People with Jacob disease in neurology, most of them they die within 1 year. So it's part of the disease that has a very bad prognosis. And how is it acquired? How is it transmitted? So people that engage in swimming in warm fresh water can easily have this amoeba form. So amoeba exists in different forms, but for the sake of exam, we don't need to know that detail because we are not doing microbiology residency. We are not pathologists. So you just know that the amoeba can enter through the cribriform plate, follow the olfactory nerve, penetrate the cribriform plate, and enter the frontal lobes. And so sorry about that. And when they get to the frontal lobes, they can affect the brain parenchyma as well as the surrounding meninges, causing meningoencephalitis. So by the time we do a CSF analysis and imaging, we are going to be seeing the amoebas in the CSF. So what you want to do is just to administer amphotericin B. So amphotericin B works for the amoeba, Naegleria fowleri. Just like we said, amphotericin B works for what?
Yeah.
For disseminated form of
Systemic
what?
fungi.
Sporotrix. Yes, Sporotrix schrenki. It works for disseminated form of or systemic form of which one again? Candida, right? We talked about
Yeah.
I want to remember which specific organism.
Cryptococcus.
Cryptococcus,
Cryptococcus
yes. So
Cryptococcus.
somebody having
Cryptococcus.
cryptococcus, you give amphotericin B plus flucytosine, with or without your fluconazole. So amphotericin B is a go-to guy with respect to those fungal infection. Then moving on to Trypanosoma brucei. So Trypanosoma brucei is a cause of the African sleeping sickness that most of us we are very familiar with. And I want to say that we have two forms of Trypanosoma brucei. We have the Trypanosoma brucei gambiens, which is a form in Gambia in West Africa, and the rhodescens, which is a form in East Africa. So the one in Gambia, which is the Gambescens, is slowly proliferating. It doesn't evolve rapidly. While this rhodescens one in East Africa is very later, it progresses fast. So we have to have a high index of suspicion, institute our treatment almost immediately in order to save the patient. So what are the phases? So we have the cytic phase, or let's just say the blood phase, and the neurologic phase. So in the hematocytic stage, you typically have symptoms like fever. So they have fever, and now there's something about this fever. The fever is recurrent. It's a recurring fever. So because the antigens on the surface of the organism change from time to time, so they are producing new new antibodies, new T cells, new P cells to respond to those infections. So the inflammatory response change from time to time. So that's why the fever recurs. Don't forget that fact. It is due to antigenic variation. They can test it. That why is the fever recurring? It is due to what? Antigenic variation. Just like the reason why we cannot have a vaccine against Neisseria gonorrhoeae. The reason we cannot have a vaccine against Neisseria gonorrhoeae. Anybody remembers why?
Antigenic variation.
Antigenic variation.
Antigenic variation.
Variants
Which
of different antigens.
Which antigen? The pili. I think we talked about it. So the pili change from
Yeah.
time to time. So you don't have any vaccine. So the same thing happens here. And later they will go and be proliferating in the lymph nodes. So there's a form of lymphadenopathy. So there's an enlarged lymphadenopathy. And later they can also have a chancre. So this chancre is a painless indurated nodular site of bite. So the painless indurated side of the bite, the fever, the lymphadenopathy occurs in the blood phase, and what is causing the bite is actually the testes fly. The testes fly is what is biting, inoculating this trypanosomal organism, right? Then later it progresses to the CNS. So by the time it gets to the CNS, you see them having an alteration of the sleep-wake cycle. That's why we call it sleeping sickness. So they tend to sleep during the day and in the night they find it very difficult to sleep. They become hepatic and tired. Sometimes they can become psychotic and they start talking nonsense. And they can be texic, they can, have some form of confusion, neurologic issues. So once you see that, you know that there's already a progression to the brain, and your treatment is going to be different. So the one we have here is the treatment for the Gambians from. So the rodescence form, rather, the rodescence form, because it is much more severe. So the rodescence is what we have here. So if somebody is having the condition at the blood phase, you can just give your suramine. But once it penetrates the CNS and you are seeing alteration of sleep cycle, apathy, confusion, psychosis, you have to give your melarsoprol. So melarsoprol. But if it's in like West Africa and the person is having the blood phase, you give pentamidine. If it's in the CNF phase, you have to give your flunitine plus nifotimux. Flunitine plus nifotimux. So let's just always remember this, because we have a high chance of being tested for this. So this is like a ring enhancing lesion for the toxo, but you expect it to be multiple. To consider toxo. This is the amoeba. This is the what's it called? The amoeba form. You can see this is also the toxo. Rather, this is the toxo. This is the tachyzoid of the toxo. This is the amoeba. From microscopy, you can see the amoeba in the CSF, and this is the trypomastigoid of the Trypanosoma brucei. So what stain is this going to be? Anybody knows?
James,
So this
James,
Yeah.
Okay. I think I have some questions here. Let me see what I have here. Okay, there's a lot. A 66-year-old man with metastatic breast cancer comes to the physician because of 2-day history of fever, chills, and new gluteal lesions. The lesions began as painless red macules and evolved into painful ulcers overnight. She received her 4th course of palliative chemotherapy 2 weeks ago, and the temperature is 38.2. Lab shows leukocyte count of 2000 with 20% segmented neutrophils. A photograph of one of the skin lesions is shown. Which of the following virulence factor is most likely involved in the pathogenesis of this patient's skin finding? Okay, let us see what is here. So we have this here, and this is a question here. So this person has.
Oh, well, can we see the picture again?
Okay. Sorry, let me bring it up. Oh. Okay, this is a picture. Does it ring any bell?
I'm wondering if this is an Eschar in Pseudomonas.
Yes.
That's very good. Very good.
Anchor.
What it looks like.
What do we call it? We don't call it Eschar. Eschar is in
Empyema gangrenosum.
Somebody said empyema where we tried.
Ecthyma gangrenosum.
Ecthyma gangrenosum. Yeah, that's very correct. Ecthyma gangrenosum. So we know this is Pseudomonas. Why? Because this person has a form of immunosuppressed state. You can see the person has a metastatic breast cancer. She's receiving chemotherapy, and her leukocyte count are very low, 2,000 with 20% segmented neutrophils. That's very low neutropenia. So that means that there's already a background immunosuppression, and the person is not developing a necrotic lesion in the skin. That is straightforward ecthyma gangrenosum for Pseudomonas. So which toxin is responsible? Anybody?
Going to be the endotoxin.
Endotoxin.
Really not.
Why are we picking endotoxin?
Endotoxin A.
Which one did we say endotoxin is working for?
Fever and shock.
So do we have shock here? There's no shock. So
Yeah.
you don't need to pick
No
it.
shock.
You don't need to pick.
Exotoxin.
So the answer is exotoxin. Yeah. Exotoxin. Yeah. So
Excuse me, sir. Why is this saying not cutaneous bacillus anthrax?
cutaneous bacillus anthrax. So number
You
one,
look
just
to
that's why we did the analysis by starting at looking at the risk factors. So this patient is having like immunosuppressed state.
Okay.
She's having chemotherapy, and when we looked at the lesion, it's not in keeping with what you expect for anthrax, because in anthrax you expect edematous borders and the central. Sorry, I'm trying to look at that image. So we don't have any edematous border here. So in anthrax, you have the border to be edematous. In fact, the lesion is not going to be erythematous like this. So in anthrax, you are just going to have the lesion confined to this one only, and the border is going to be what's it called, edematous, and you see a central necrotic lesion. Do we understand? So this is actually ecthermal gangrenosis. You can see the erythematous lesion and the central area of the gangrene. So,
Okay.
So moving on to am I moving on to anything?
the next question.
I think the question is
Yeah,
still on the question.
there's another question below.
You said it's a lot of.
What?
You said it's a lot of questions.
Oh yes, that's true. Sorry, it's not a lot. I think I have two. They are just long. So a a 2.9 kg male born is delivered at term to a 29-year-old primary woman. His mother has no routine prenatal care. She reported that the pregnancy was uncomplicated, apart from a 2-week episode of low-grade fever and swollen lymph nodes during her early pregnancy. She has avoided all routine vaccination because she believes that natural immunity is better. The newborn is at 35 percentile for height, 15 percentile for weight, 98 percentile for head circumference. Endoscopic examination shows inflammation of the choroid and retina in both eyes. A CT scan of the head shows diffuse intracranial calcification and mild ventriculomegaly. Prenatal avoidance of which of the following would have prevented this newborn condition? Spot diagnosis.
Congenital
Congenital
toxoplasmosis.
Congenital
Toxo.
toxoplasmosis. We can see the chin. The C standing for which, the chorioretinitis, the H standing for the hydrocephalus. They told us there's a mild ventriculomegaly, and the IN standing for the intracranial calcification, which you expect to be diffuse. So what is the risk factor here?
Undercooked pork.
Undercooked meat, or exposure to cat feces, or from what? Placenta.
Can you show the question again? Sorry, sir. Can you show the question again?
Okay.
All right. Thank you.
Welcome.
Thank you.
Okay. Sorry, just 1 minute. Let me respond to this person. I'm so sorry about this. Oh, the person is in already. Okay. So moving on. So we are moving on to the protozoal malaria, and I know that all of us, we know this one very well. The organism that causes malaria is a plasmodium, and it is being transmitted by the female Anopheles mosquito, and the presentation typically includes cyclic fever. So it's cyclic because it follows some cyclical pattern. It could be 48 hourly, 72 hourly, or irregular, depending on the strain of the plasmodium that is involved. And they have other constitutional symptoms like headache, they are prostrated, they have malaise, they could have anemia, if it's severe, can have a splenomegaly, they can have hypoglycemia. So they can have kidney injury, they can have lung injury like pulmonary edema, they can have liver injury with elevated liver marker. So depending on the severity. So how do you identify malaria? Just do your peripheral blood smell. And you can do like two films. You can do the thin and the thick. So the thick is there to make your diagnosis, because that's how it's used to like do the initial screening, best initial test, because it has very high sensitivity. So it can show you the organism with the quantity of the organism, the quantity of the organism. So if you want to count, use your thick smell. But your thin smell is going to fine-tune that detail of the organism and tell us if it's P. malariae, if it's P. vivax, or just tell in between persons if it's me or Dr. Festus. So I need to do a thin smell to look at it well, to delineate, okay, what am I looking at? But if I want to count how many organisms is there, I do the thick. So the best initial is the thick, which is highly sensitive, but the one that is very specific is the thin. So very important. So how do you treat generally? The person is sensitive to, if the organism is sensitive to chloroquine, you can give chloroquine. But most of them in this world now, they are chloroquine resistant. So you start with your mefloquine, your doxy, or your atovaquone proguanil. Please don't ever make the mistake of picking atovaquone or proguanil separately. You will 90% of the situation, that person is going to be wrong. So always pick them only when they are combined. Atovaquone and proguanil. Or you are using doxy, or you are using meflo. So if somebody is pregnant now, you might not be able to use doxy, but you can use your meflo. So, but if somebody is having a life-threatening malaria, somebody is having malaria that the person is having seizures, the person is having prostration, cannot stand up, the person is having splenomegaly with anemia, the person is having hypoglycemia, the person is having AKI, pulmonary edema, end organ failure generally, you have to give a more, what's it called, a more effective form, which is intravenous quinine, and in Nigeria we use artesunate a lot. We know this artesunate by combination therapy. So artesunate or your quinine, and in the US they believe that you have to assay for your glucose 6-phosphate, because maybe the artesunate can trigger some form of hemolysis, with people with G6PD deficiency. Then moving on to each of those organisms specifically, and before I do that, I am just going to show us an image that talks about the malaria life cycle, because we can get tested on this part. So the first is that the female Anopheles mosquito comes in and tries to take a bite, and it takes a bite from the skin, and what it's picking is actually the gametocyte. So it's picking the gametocyte from the individual's blood. So, and when that happens, the gametocyte, they come together, the micro and the macro, they come together and they form some organisms, which we are not expected to know. When they come together, they will develop like this, and they will reach to the sporozoite. So we are expected to know that the sporozoite is being taken in by the malaria, gets into the belly of the female Anopheles mosquito, and when the female Anopheles mosquito takes another bite on another human, it releases the sporozoite in its saliva. And these sporozoites, they have high affinity to travel through the bloodstream or the lymphatics to the liver directly. So they go to the liver and the life cycle continues. So in the liver, they are converted to the schizoids. And so this is the sporozoite, which is looking like a worm. It gets converted to the liver schizoids. The schizoids. Now, this liver schizoid, they can differentiate along two pathways depending on the species. So if the species of the Plasmodium that the female Anopheles mosquito is speaking is the P. vivax or the P. ovale, when they release the sporozoite and the sporozoites differentiate into the liver schizoids, it differentiates further into the liver hypnozoites. So that is peculiar to Plasmodium vivax and ovale only, and they stay and keep themselves dormant in the liver cell. So that's the hypnozoite. Now, this is very dangerous because they can easily reactivate themselves back into functional schizoids, and that can differentiate into merozoites that can affect the red blood cell. So we don't want this air. So that means that we have to give an additional drug to eliminate this, and that is where primaquine comes in. But if it's just the P. malariae or the P. falciparum, they don't go and differentiate to this hypnozoid form. So they just continue as a liver schizoid. They form the merozoid. So this one we're having here are the merozoid. The merozoid will attack the red blood cell, and after they attack the red blood cell, they differentiate to form immature trophozoid. So this is the form that we usually see in the smear, the mature and the immature trophozoid. These are the ring form that we usually see when we do our peripheral blood smear, because we can't see the form in the liver. It is the ones that is in blood that we see. So the immature trophozoid, the mature trophozoid, it will form the blood schizoid, not the liver schizoid now. The blood schizoid, then the blood schizoid differentiate back into the merozoid, and the merozoid will break off from the cell. So that is the reason why you have anemia, because when they break off, they lyse the red blood cell and they release themselves again into the circulation, and the fever starts again. So once they burst the red cell and they enter into the circulation, you have inflammatory response. And part of the inflammatory response, cardinal signs, what? Fever. So there's fever again. So the time it takes them to complete this cycle, that's the time that the fever will be recurring. So if it takes them like 48 hours, it means that the fever will be recurring every 48 hours. It takes them 72 hours. The fever will be recurring every 72 hours. If it's irregular, they are infecting different red blood cells at different times, bursting at different times. It means that the fever pattern is going to be irregular. So this cycle is very important. And some of the mature trophozoites goes to differentiate into the gametocyte that is going to be picked up by the female Anopheles mosquito, and the cycle starts like that. So,
So,
so the people.
Wale, can you elaborate a little bit more on that, the trophozoite one, where the Plasmodium malaria and falciparum does happen?
Which part? The
That,
trophozoite?
yeah, the trophozoite going down.
Yeah, so don't worry about this going down. Just know that the trophozoite just forms the gametophytes, the gametocytes. These gametocytes, these are the male and the female that couples to form new gametes. So they come together, and this is what is picked by the female Anopheles when it takes a blood male. So it takes these two will copulate again, they will start again, and they will form the sporozoites. So when it takes another male, it will transmit the sporozoite, and the cycle goes like that, because sporozoite will now go to the liver and form the liver schizoid that goes down to form the merozoite, burst the red cells, and everything starts like that.
Okay, the part I want to get is the one where they bust the red blood cells and form fever, like reoccurring fever. Can you write that part?
So
The last.
when there's the liver schizoid will differentiate into the merozoite. The merozoite release into the red blood cell. The mature in the red blood cell has immature trophozoite. Then from immature trophozoite to mature trophozoite, then the mature trophozoite back to the blood schizoid, then blood schizoid back to the merozoite, then the merozoite will rupture, and they'll go and infect new cells. When they infect new cells again, they'll form immature trophozoite, mature trophozoite, blood schizoid, merozoite, rupture again. New cells cycle like that. So it depends on how long this cycle is completed. So if it takes 48 hours, it means that the fever is going to be happening every 48 hourly. Is it clear to us?
Mm-hmm. Okay.
So that is the way it works. So for P. malariae, it takes 72 hours to complete the cycle. So that's why they have a 72-hour fever cycle. I call that the quartan fever pattern. And what you see if you do the smear is a trophozoite ring, in the red blood cell. For P. malariae and Vivax, their own cycle is 48 hours, and you call that the tertian fever pattern. But don't forget that we said that they have the dormant form of the hypnozoite in the liver, right? And if you do the peripheral blood smear, you are going to see trophozoite clearly. But in addition to that, you have some granules in the cytoplasm of the red cell that we call the Schaffner striplings. So this is what it looks like. So you see the trophozoites, which you can see in P. malariae, P. Vivax valley. But in addition to this, you see this granules. So once you are seeing these granules, you know that this is likely to be the Schaffner granules or the striplings with the P. vivax or the P. ovale. So, is there anything I'm missing? No, sorry. This is not what I'm supposed to identify. This is the granule. I'm so sorry about that. This is the granules. These are the granules here. The Schaffner granules, not this. Because I was wondering that this is something. This looks like the gametophytes. So this is the Schaffner striplings here. I'm so sorry. This is tiny stuff like this. So for the P. falciparum, the fever pattern is very severe and irregular. So once you see that the fever pattern is said to be irregular, you know that it is P. falciparum until otherwise proven. And this one has it because the parasitation in P. falciparum, the amount of the parasites that clogs the vessel is very high. So they have a very high chance of clogging the vessels of the brain, the kidneys, the lungs, and causing cerebral malaria, AKI, pulmonary edema, liver issues, and the like. So that's why P. falciparum is implicated in causing the severe form of malaria. So what are we going to see on the peripheral blood smear? So we can see the gematocyte, which is a form that is going to be picked by the female Anopheles, and we can also see the trophozoite, but the trophozoite are going to have a headphone patterning, like as if they have two nucleus, so 1 and 2, 1 and 2. Once you see this, just think about P. falciparum, as the implicating infection. So headphone shaped trophozoite ring, very, very important, with a crescent shaped gematocytes. The last one that we have here is babesiosis. So this is very simple. Once you see a question talking about somebody having fever with hemolytic anemia, so somebody having fever with hemolytic anemia, and there's a background risk of asplenia, maybe the person's having sickle cell anemia and the person has undergone autosplenectomy like around 4 years, or the person had a road traffic accident and they had to remove the spleen, and later the person is now developing fever and hemolytic anemia in the US, not in Africa. Please, we should not go and make that mistake. In the US, fever, hemolytic anemia with a background asplenia in the United States, know that the diagnosis is likely to be Babesia microti. And we know that the vector for this Babesia organism is a BAB, transmitted by the ixodes stick. So the BAB of the ixodes stick will transmit the Borrelia burgdorferi, the anaplasmosis, as well as the what? The Babesia. So what did we say we have to look out for with respect to anaplasmosis? What do you look out for?
The morule, you find them.
Morule
It can
where?
be in the monocytes or in the granulocyte.
So which one has
Oh.
morule in granulocytes?
That should be the anaplasma.
Yes, so anaplasma has morule in the granulocytes, while the erythrocytes has a morule
Erythrocytes
in the monocytes.
in monocyte.
Monocytes.
So what do you look out for on the peripheral blood smear? So you look out for the Maltese cross appearance. So what you see is we see the ring form of the trophocytes, and at the same time we notice that we have 4 merozoites cross-linked together forming the Maltese cross. Once you see this on the smear, your diagnosis is going to be Babesia until otherwise proven. Babesia until otherwise proven. The treatment for this guy is AA, atobacone with your azithromycin. Atobacone with your what? Azithromycin. AA, atobacone with azithromycin is what we use to treat Babesia infection. So the patient can be having fever, hemolytic anemia with hemoglobinuria. The hemoglobinuria can even precipitate AKI. So it can be that bad. So have that at the back of your mind. See somebody having jaundice, abdominal pain, fever, asplenia, and there's, they did this smear, they are saying this, that is Babesia microti. So moving on to, do you have any question here? Okay, let's see. An otherwise healthy 65-year-old man comes to the physician for a 2-year history of recurrence of abdominal pain and fullness that wasn't after meals. Urea breath test is positive, and endoscopy shows diffuse mucosal atrophy and patchy erythema, but no ulcer. A biopsy from which of following area is going to yield the most accurate diagnosis? Anybody?
Gastric
Gastric
antrum.
antrum. That's very easy. Peptic ulcer disease. A 64-year-old man is brought to the emergency department because of fever, chills, shortness of breath, chest pain, and a productive cough with bloody sputum for the past several days. So there is shortness of breath, fever, chest pain, and productive cough. Okay, and he has metastatic pancreatic CA and is currently undergoing polychemotherapy. There's fever, and examination shows scattered inspiratory crackles in all lung feet. A CT scan of the chest shows multiple nodules, cavities, and patchy areas of consolidation. A micrograph of the specimen is shown below. So let us see what we have here. So what do we have here?
Looks like
Hypertrophy.
45 degrees.
Acute angle palpation. Yes.
Okay, so which one are we going for?
Aspergillus.
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 Aspergillus is correct. Aspergillus is correct. You can see there's cavitation probably. Maybe they had like tuberculosis or something that this guy is not colonizing. And of course, there's widespread inspiratory crackle. That means that it's invasive. It's affecting all the aspects of the lungs. And what else am I going to say? Then the histology picture is also showing us the 45-degree branching, which is a classic for aspergillus. You can see the branching at 45 degree, branching at 45 degree. So that's that. Okay. So moving on to the visceral protozoa. So we have talked about the hematologic ones, Then moving on to the visceral ones. So the protozoa have tendency of affecting the organs. So the first is Trypanosoma cruzi. So the first thing to know here is that the insect, the vector for Trypanosoma cruzi is a tryptomine insect, which is a kissing bug. And this guy, whenever it takes a kiss or bites any part of the skin, it will defecate. And that fecal stuff is going to contain this Trypanosoma cruzi trypomastigoid, and from there it gains entry into the blood. So it can defecate around the mouth or the eyes. So most commonly defecate around the eyes, and that's why they have a unilateral periorbital inflammatory response, which we call the Romaner sign. So if we see a patient that is having unilateral periorbital swelling, one of the diagnoses we want to consider is the Romaner sign of Trypanosoma cruzi. And mind you, this occurs in the acute stage. Now, when the Trypanosoma cruzi trypomastigoid now gains entry into the blood, it starts attacking some three organs: the heart, the colon, and the esophagus. So it destroys the myenteric and the submucosal plexus of the colon, as well as the myenteric and the submucosal plexus of the esophagus. And in that situation, it's going to lead to difficulty in relaxation of lower esophageal sphincter. So the person is going to be having a form of achalasia, and when we can't have adequate relaxation of the lower esophageal sphincter, we can't propel food from the mouth to the stomach again. So food is going to be pulling up in the esophagus, and there's going to be mega esophagus at the end of the day. The same thing happens in the colon. The myenteric sphincter, the myenteric plexus is gone. The submucosal plexus is gone. The onward propulsive movement of the colon is lost, and you tend to have stasis in the colon, leading to dilatation of the colon, causing megacolon. So they present with abdominal pain and constipation because of this. So enlarged colon with abdominal pain and constipation with megaesophagus, think about Trypanosoma cruzi. And the last is what? Dilatation of the heart. So you have a form of dilated cardiomyopathy, and this can be associated with all these things I've listed here. You can have heart failure because of this dilated cardiomyopathy. They can have a mural thrombus. They can have a ventricular aneurysm in that dilated heart chamber. So We should have that at the back of our mind. And these are the chronic manifestation. The acute one is what? The periorbital swelling, which is what we call the Romana sign. Don't forget that. So you see the trypomastoid when we do the blood smear, which is this. Very similar to what we see in the Trypanosoma gambians, Trypanosoma brucei. So we might not be able to separate them, but the history is going to help us. So how do you treat? Because all these things are big things. Megacolon, megaesophagus. So where we used to remember it is just to picture this word, bends. So people that drive bends are usually big people. So bends nidazole, is used in the treatment of Trypanosoma cruzi as well as in Nicotinamx. Nicotinamx is part of the drug we use to treat Trypanosoma brucei. What's it called? Gambians. So we said we combine it with eflornithine, particularly people with the CNS aspect of it. So moving on to Leishmania. So Leishmania is one of those commonly tested organism too. We have three forms of Leishmania. We have the visceral Leishmaniasis, we have the cutaneous Leishmaniasis, and we also have the mucosal Leishmaniasis, which is not stated yet, but we have the mucosal form. And the skin form, we just have skin ulcers. Basically, we just have like papules in the skin that ulcerate. And I think we have one here. This is, see the skin ulcer, the papules. This is the initial papule or the plaque that became ulcerated, having this. So this is the cutaneous leishmaniasis. And most likely this person got bitten by the what? The sandfly. So don't forget the kissing or the triatomine insect for cruzi, and for leishmania, it is sand fly. So get bitten by the sand fly, they have a cutaneous form. For the mucosal form, so it usually affects the nose. So they will have like nasal congestion, they can have like atrophic like crusting in the nose, they have like necrotic debris like that in the nose because of the inflammatory response there. It can also affect the mouth, and I think I have a note here, and they can have problems with the pharynx, bleeding in the nose too, scabs in the nose, in the pharynx you have bleeding, difficulty in swallowing, painful swallowing, and brassy cough. That's the mucosal manifestation. Why the visceral manifestation is what we call visceral leishmaniasis or Kala-Hazard or Donovanosis. So, and what we usually see is that we are going to notice that the fever is going to be spiking, like very high, and we are going to be seeing some affectation of the viscera, like the liver and the spleen. So there's going to be hepatosplenomegaly, there's going to be lymphadenopathy, and it can also affect the lymph nodes and the bone marrow, causing pancytopenia. So a patient having spiking fever, hepatosplenomegaly, big liver and big spleen with bone marrow suppression. This is very classic for what? For visceral leishmania. It's also, we also have a close differential. Anybody remembers what is close differential? Can anybody remember? Fever, hepatosplenomegaly, pancytopenia. We talked about it yesterday with oral ulcers, palatal ulcers. Anybody remember? Huh? Histoplasma. Yeah, that's very good. Histoplasmosis, very important. So the os of histoplasmosis, hepatosplenomegaly, palatal ulcers, they can have pancytopenia too. So that's why you need to do your imaging. Now, it is so difficult that the imaging even now looks the same thing, similar. Because if you remember in histoplasmosis, what did we say we are going to say on histology? Anybody remembers histology of histoplasmosis? What's going to look like? Can anybody remember? Okay.
Macrophages inside.
Intracellular, like
So what's going to be in the macrophage? The yeast.
The histoplasma.
You see the yeast. The yeast. You see the yeast of the histoplasma in the macrophage. So this is the macrophage here. You can see the yeast. Now, but this one, what we are seeing is the amastigoids. So these are the amastigoids of the Leishmania organism in the macrophage, which is very similar to what we see even in histoplasmosis. So, but people that work in the lab, they have special eye that they use to identify all those things. So once you see them stating mastigoid in the macrophage, you know that is likely to be Leishmania. So we have two forms. We have different forms actually. We have the Leishmania mexicana, so that's the one that causes the cutaneous stuff, while the Leishmania donovani is the one that causes the visceral form. So that's why we call the visceral leishmaniasis donovanosis. So how do we treat? Just give them amphotericin B, or you give them sodium stibogluconate. Amphotericin B or sodium stibogluconate is what we use. For the sexually transmitted one, there is Trichomonas vaginalis, and it's a cause of vulvovaginitis. So the patient typically presents with foul-smelling greenish discharge. So they have this foul-smelling greenish, discharge, and they could be complaining of vaginal itching, burning sensation in the vagina. Maybe when they are peeing, it's very painful. When they're having sexual intercourse, it's also very painful. And you don't want to confuse this with Gardnerella vaginalis. This is a gram-variable bacteria that we talked about, yesterday. So don't confuse with Gardnerella vaginalis. And we said yesterday that Gardnerella vaginalis is not sexually transmitted, but it is related to what? Sexual activity. So, but Trichomonas vaginalis is actually sexually transmitted. In fact, it cannot exist outside the human host because it does not form cyst. If it forms cyst now, the cyst could be hiding maybe in water, sand, soil, or anything, but it has no capacity to form the cyst. So most of them, they exist in the trophocytic form, which is the tissue form, and they are always staying in human cells. So it's being transmitted sexually, and when we do like a wet saline mounting, we are going to see the trophozoites, which are motile because they are flagellated. So once you see this in somebody having vulvovaginitis, just go and pick your Trichomonas vaginalis and you move. And to further confirm that what we are dealing with is Trichomonas vaginalis, you notice that the cervix is going to have punctate cervical hemorrhage. So strawberry cervix, strawberry, strawberry cervix, it's classic for vasculitis. And see this punctate hemorrhage. So once they show us punctate cervical hemorrhages, this trichomonasis until otherwise probably. So how do you treat? Give them metronidazole. Metronidazole, just like we give people with entamoeba histolytica, we also give people with trichomonasis metronidazole, and we make sure we do a contact tracing to treat their partners. We have to give them prophylactic treatment and also check them for STI. Very, very important. Very, very important for trichomonasis. So let me see what I have here. Okay, so this is another question, but I don't have question on all these protozoa yet, so but we are going to see questions on them too later. A 26-year-old man comes to the emergency department for evaluation of burning with urination and purulent urethral discharge for the past 3 days. He's sexually active with multiple female partners. Several months ago, he was diagnosed with urethritis caused by a gram-negative diplococcal and received antibiotics treatment with complete resolution of symptoms. A gram stain of the patient's urethral discharge shows gram-negative intracellular diplococcus. Which of the following properties of this infecting organism most contributed to the pathogenesis of this recurrent infection?
Gonorrhea. So that should be the
So that's gonorrhea.
Yeah.
So
Variation
variation of the express. Yeah, I agree with you.
Doc, I didn't even hear what the conclusion. Please, can you go back and because everybody was talking.
Yeah, so the answer is variation of the expressed pillar. So this is Neisseria gonorrhea. Neisseria gonorrhea.
Yeah. Okay, thank you.
Okay, so now we have the nematodes. So the nematodes are a little bit they are straightforward. So we don't need to complicate the stuff. We just need to keep it simple. So the nematodes that we have, the ones in the intestine, and we have the tissue form. So this first one we'll be talking about are the ones that they are restricted to the intestine. And the first one is Enterobius vermicularis, which is also known as pinworm. Enterobius vermicularis, pinworm. So we have to be able to remember the name. So very important. So what is peculiar to it is that it causes anaphoritis. It's as simple as that. Once you say a patient having anaphoritis and nothing else, that is Enterobius vermicularis. And the pruritus very worse at night because that's when the mother worm is going to come out to lay the eggs. So and the eggs can cause some form of irritation leading to the pruritus. And we visualize it by doing the Scotch tape testing. So we apply the tape at night and in the morning we collect it because we believe that the tape would have been attached to the eggs by that time, and we examine the tape in the morning to check for the eggs. So it's very common in children between the age of 5 to 10, and it's transmitted through the fecal-oral route. So the major drug that we use in treatment of nematodes, the roundworms, is the benzadole, the bendazole. So albendazole, mebendazole, any of those bendazole, you use them. But for Enterobius vermicularis and Encyclostoma organisms, or Necator americanus, which is hookworm. So hook and pin, both of them can cause pain. You pin, hook, pin, they are sharp. So both of them, they are similar in the terms that you use your bendazole and your parenteral palmate to treat them. So that's that about Enterobius vermicularis. For Ascaris lumbicoides, so Ascaris lumbicoides is one we are very common with, and that is the giant roundworm. And what happens is, I think I have the life cycle somewhere here so that we can see as I'm going to be saying it. So the way it gains entry is important because it can be tested. So the host ingest the eggs, maybe from water or from something that is contaminated with the fecal matter, maybe food. And the eggs, they hatch and release the larva in the intestine. So this larva will invade the intestinal walls. So when the person takes in the egg will hatch into the larva. The larva will now invade the intestinal wall and it will try to migrate into the lung. So what happens is that it penetrates into the wall of the intestine and it finds its way into the portal vein. And remember that the portal vein, supplies the liver and later empties into the hepatic vein, and the hepatic vein drains into the IVC. So from there, it can return back, to the heart, to the right side of the heart, then to the lungs. Just picture that something empties into the hepatic portal vein, the hepatic vein, and the IVC. The IVC takes it back to the right side of the heart, to the right atrium, to the right ventricle, and into the pulmonary vessels. And when it gets to the pulmonary vessels, we know that in the pulmonary vessels here, they are just supplying the lungs. So this is the lungs. This is the pulmonary vessel. So they can easily breach this vessel and get into the alveoli. So when they get to the alveoli, they can enter into the trachea too and the larynx. And from this area now, they can be expectorated back into the mouth. So they just cough it out, and it's taken back into the mouth and swallowed back into the intestine. So don't forget, it is the larva that they are swallowing back into the intestine. So when the larva gets into the intestine, it can mature into the worms. The worms will lay new eggs. But these worms in the intestine can constitute problems in the intestine by causing obstruction and malnutrition. Or malabsorption rather. So now we have seen the life cycle, and we are going to be talking about how it causes a problem one by one. So the larva gets back into the intestine after being carved out from the lungs, and they can obstruct the narrow part of the intestine, which is at the ileocecal valve, causing intestinal obstruction. They can also find their way into the biliary tract, causing biliary obstruction. They can be too much that sometimes they can even perforate the intestine at the end of the day. And we have talked about the fact that they migrate so sometimes they can even find their, so when they are in the lungs, sometimes they can find their way out like that, through the lungs out to the bronchial. You know that the lungs is made up of let me see. So we have the trachea here, we have the bronchial airways here, and the bronchial airways further divided into the alveoli, the bronchioles, all those anatomy. Then they can find out because they gain entry initially into this alveoli from the pulmonary capillary. So they can enter into the alveoli there, and from here they can migrate upwards to the bronchioles. They go from the bronchioles to the bronchi, which is the main bronchi, then they move upward like this to the trachea and upwards to the larynx, and from there they get coughed. Ha! You know that just in front of the trachea we have the esophagus, so you can get coughed like this, bam, and they jump into the esophagus, and from there they are swallowed again back into the stomach, and from there they find their way into the intestine. So when they are in the lungs, they can trigger what we call the Loeffler syndrome, in which you start seeing them having symptoms of chest pain, they're having cough, chest pain, they can have wheezing, and if you try to do a culture of your pulmonary expectorant, like maybe the sputum or something, we are going to be finding features of pulmonary eosinophilia. So you see that the eosinophil count is elevated because we're having IgA response against these parasites, and one of these cause of elevated eosinophil is what? Parasitic infection from our hematology. So, and some of them can migrate up to the nose and the mouth, just like we have said, and basically that's just ascaris for us. They can cause obstruction of the intestine, obstruction of biliary tract, intestinal perforation. They migrate to the alveoli and cause the Loeffler phenomenon, which is characterized by chest pain, dyspnea, wheezing with pulmonary eosinophilia. So how do you look at them? You see them having knobby coated eggs. So the knobbly coated eggs means that the coating is very thick and it looks just like this. So this is the egg of Enterobius vermicularis, and this is the knobbly coated egg of Ascaris. You can see that this one is definitely thicker than this. So that's how it looks like. Now, the next is the Strongyloides stercoralis. Now, the difference between this one and this one is that the Strongyloides stercoralis majorly gains entry into the the body from the larva. So it penetrates the skin. So the Strongyloides lay eggs attach human intestine and they release the larva. So what happens afterwards? The larvae are excreted in fecal matter and they contaminate the soil. Now, the larvae penetrate the intact skin of a definitive host upon contact with contaminated soil. So somebody that is, in contact with contaminated soil containing the larva can easily have the larva migrating, penetrating the skin, entering into the blood vessel, and from there migrating to the lungs, just like ascaris, right? And from the lungs, they can also enter the bloodstream. Sorry, they migrate to the lungs via the bloodstream. So when they get to the lungs, they can migrate upwards, to the pharynx, and from there they can be swallowed, causing autoinfection. So the cycle goes like that. So autoinfection in that they get swallowed back into the GI, they penetrate the GI wall again, they enter the vessel, they go up again to the lungs. From the lungs, they migrate up again to the pharynx, they get swallowed back into the esophagus, down to the stomach. So autoinfection, like that, like that, like that, like that, like that. So some of the larvae will now mature into the adults and they will start laying the eggs in the intestine. Now, some of the eggs will develop and they will be excreted in the feces. And now the feces will now release the larva. The larva again will now enter by penetrating the skin of somebody that is in contact with that soil. The larva will find a way into the blood again when they penetrate the skin. And when it finds its way to the blood, they will enter again into the vessels supplying the lungs. And when they migrate from the vessels, they enter into the lungs. They proliferate in the lungs and they migrate upwards again to the pharynx, esophagus. They get swallowed down. Everything starts like that, like that. But majorly, Strongyloides stercoralis typically affect the duodenum in the small intestine. So it is not like ascaris that will be causing obstruction of the bowels. Strongyloides is not like that. So just cause inflammation of the duodenum, and they present with abdominal pain. So they can have nausea, they can have vomiting and abdominal pain because of the duodenitis. So that's the first thing that should always come to our mind, that okay, if this cycle is kind of similar, what can I use to differentiate? Okay, Ascaris is a very big guy. A lot of worms, they can obstruct the ileocecal valve, they can obstruct the biliary tract, they can perforate the intestine. But strongyloides is not as big as this giant roundworm. So they will just cause inflammation of the GI, particularly the duodenum, causing duodenitis, which presents with abdominal pain, nausea, and vomiting. And because of the fact that I've said that they find their way into the lungs, so they can also cause something that looks like the Loeffler syndrome, and they can have dry cough and hemoptysis. And of course, don't forget that we said they gain entry through the what? Through the skin penetration from the larva. So definitely there could be some pruritic manifestation at the point of entry. And we've said that hyperinfection syndrome can be caused by accelerated autoinfection in autoimmune in immunocompromised patients. So people that have some immunocompromised state that they cannot keep that virus, that worm in check. It keeps moving up like that through the lungs, to the esophagus, down to the bowels, penetrating the bowel wall again to the blood vessel, back to the lungs, like that, or hyperinfection. So how do you make the diagnosis? You see the larva in soil penetrating the skin, and if you check for the feces, you are going to definitely see the rapidiform larva, under the microscope. So don't forget that the larva is a mainstay of problem here in the strongyloides, while the ascaris is the eggs that is consumed that will now start developing to the larva, then adult. But this one, it is the larva that started the problem. And how do you treat? Because this one is very, very, it's quite different. So you use ivermectin, and of course the benzodiazole, because they are nematodes, the bendazoles, and ivermectin for strongyloides stachydis, and strongyloides stachydis, also known as a thread. So Astine as a threadworm, that is why it does not cause obstruction. Astine as a threadworm. So moving on to the Ancyclostoma species, or the Necator americanus. So you have to know these names: Necator americanus and Acyclostoma species. So both of them constitute the hookworms. And what do you need to know about hookworm? Nothing. You don't need to know much. Just know that hookworm, just like Strongyloides stachydis, both of them, they gain entry into the skin through the larva. And now I have to mention something here, that the migration of the Strongyloides stachydis through the skin causes what we call the larva current. So that pruritic stuff that we are talking about is what we call the larva current. The larva current. So it's very similar to the larva cutaneous cutaneous larva migrants we have in hookworm. So somebody is walking in the beach, no slippers, nothing. The larva of this hookworm, the Necator americanus and the Acyclostoma, can penetrate to the legs, and they find their way into the blood. But they would just focus on the intestine. That's what they do. And they start developing the intestine, and they form hooks that will not attach to the intestinal wall, and they are just enjoying their meal and be sucking blood. And at the end of the day, that individual is going to suffer iron deficiency anemia, which is a form of microcytic anemia. So there's going to be presence of the cutaneous larva migrants at the site of entry, through the skin, which is very pruritic and have a snake-like pattern, which I'm going to show us shortly. How do you treat? Just like I've said, the hookworm and the pinworm, they are the same thing. You treat them by giving bendazole and parenteral palmate. So this is the, what's it called? The hookworm entering into this person's hand, and this is serpiginous cutaneous larva migrant. So moving on to Trichinella spiralis, and this is also caused by the larva entering the bloodstream. The person takes the cyst. So usually this one is due to somebody eating the cyst, not the egg. So somebody takes meat that's undercooked, that is then cysted with the larva. So once the person eats that meat and it gets to the GI, the acids in the GI is going to lyse that cyst, and is going to release the larva into the bloodstream. And when it gets to the bloodstream, it's going to be traveling all over the body, and it gets to the muscle, encyst again in the different part of the muscle, causing myositis. So the person can be having symptoms of myalgia, muscle pain, and there's something called trichinosis. So that's more like the constellation of fever, the vomiting, the nausea, because when they enter the bloodstream, they find their way to the muscles, they find their way to the intestine. They can cause nausea, vomiting, diarrhea because of that. And the periorbital edema is something I have to mention because it's believed to be due to an inflammatory response when it's moving across the face. So inflammatory response to that organism causes periorbital edema. Which other condition did we say we can have periorbital edema that is unilateral? Anybody remembers?
Trachoma cruzi.
Cruising.
Yes, so that's the Romanal sign. We also have something that looks like Romanal sign here, but in cruzi, we're not going to be having muscle symptoms. So once you are seeing myositis with intestinal symptoms, periorbital edema, that is trichinella until otherwise proven. And it means that the person must have eaten undercooked meats, that contains a cyst, that contains the encysted form of the larva, that contains the encysted form of the larva, which is released when it gets to the GI. And the larva is going to be traveling to the muscles, the intestine, the face, and be causing all these things. Treat with your bendazoles. I'm going to ask those questions shortly to see if you actually have an understanding of all these things. I think I have 1 or 2 questions here. So here is let's meet our mic, please. This is Trichuris trichuria, and it's also known as whipworm. And all we need to remember with respect to whipworm is that it can cause loose tooth. Usually it is symptomatic, but if it's symptomatic, you see loose tooth and then what's it called? Attachment to the intestine, causing iron deficiency anemia too, and rectal prolapse. So this rectal prolapse is the most important presentation that we should always put at the back of our mind. Okay, so let's just round up with the tissue form. So these are the ones that enter into the tissues, and the first that we have. So don't forget rectal prolapse, loose tooth, and anemia for trichuris, rectal prolapse. So what we have for the tissue form, nematodes, Toxocara canis. So it means that this guy is actually entering different viscera. So once somebody takes in the larva, it enters into the intestinal wall, and from there find its way into the blood. Then it will disseminate to different organs. That's why we call it tissue or visceral nematodes. So they go to the liver. They can cause hepatosmegaly and abdominal pain. They can go to the lungs and then cause dyspnea, difficulty in breathing, wheezing, cough, pneumonia, which is very similar to Loeffler syndrome. The skin, some rash in the skin. They can go to the heart and cause myocarditis, inflammation of the heart muscle, which can present with heart failure, tachycardia and all those things, dyspnea. And it can also get to the CNS and cause confusion, seizures, coma. They can go to the eyes and, migrate to the eyes and cause problem with vision, like strabismus, leukocoria, inflammation and scarring, with even detachment of the retina. So this is just organ manifestation, like gets to the heart, myocarditis, gets to the CNS, cause seizures and coma, gets to the liver, hepatosmegaly, eyes, visual impairment. But usually, most of them, they are asymptomatic. But if they are going to be symptomatic, they are going to be presented with signs and symptoms of viscera, they get liver migrants. So affecting different viscera, they migrate into the blood and cause inflammation in different viscera. So still give your albendazole, Then so this is a encysted larva in. Anybody can guess what this is?
Spiralis.
Yes. So
Spiralis.
this is
Trichinella
Trichinella
spiralis.
spiralis encysting within the muscles. So Onchocerca volvulus, typically present with, is caused by bite of the female black fly. So I think we call that river blindness. It can cause river blindness. So once the host is bitten by a black fly, the larva of this Onchocerca volvulus is released into the bite wound, and it will mature into the adult worm, which likes staying in the subcutaneous tissue on the muscle. So the adult worm will reproduce there, and they will form the microfilariae, which will now further penetrate into the subcutaneous tissue. And in that subcutaneous tissue, they can form a lot of what's it called? Inflammatory response, which can lead to some skin changes. So we are going to show us, I think I have one here. And from there, they can also migrate to the eyes, so causing some ocular changes like keratitis, red eyes, uveitis, optical atrophy, so many things, and some skin changes which can have like pruritic lesion and hyperpigmented purple. So like, let's just be familiar with the leopard skin appearance, hyperpigmentation, hypopigmentation that we see. So once you see this hypopigmentation, in somebody, think of onchocerciasis, and they will have told us that this person is also having visual problems. So blindness due to uveitis, keratitis, retinal detachment, so many things like that. With these skin problems, hypopigmentation is in keeping with onchocerciasis, and it is the Simulium blackfly that is responsible, for these problems. And you want to give ivermectin to treat. Ivermectin that we use in treating Stachyoralis strongyloides. Hope you remember Stachyoralis strongyloides. Is also what we are going to use in treating this onchocerciasis. The next is lower. So lower causes loasis, and we just noticed that this deer fly, horsefly, mango fly, any one of them, not black fly. So the mango fly, the horsefly, the deer fly, they bite and they introduce the microfilaria of this guy, and it enters into the skin and causes skin swelling, inflammation at that site. And from there, it can also migrate to the eyes and cause a worm in the conjunctiva. And we just see that the worm is migrating across the eyes like that. So this thing is still saving. So sorry, I'm not be able to move my cursor very well because I'm still saving the file. And so I'll show us the image shortly when this thing is completed. So we just see that the what's it called? The worm is just migrating across the eye like that. So that is loasis. So you have to give diethylcarbamazine. So not ivermectin, but diethylcarbamazine. Then the last two include the lymphatic filarial, organism. So the lymphatic filariasis that cause elephantiasis. So the first is Wuchereria bancrofti, and we have the Brugia malari. So the worms, of this Wuchereria bancrofti and this Brugia malari, they invade the lymph nodes. So once the female mosquito comes in and takes a bite, it will release the larva of this Wuchereria bancrofti and the Brugia malari, which are going to develop into the worms, and they will start invading the lymph nodes, causing inflammation and fibrosis. So when there's inflammation and fibrosis, at the end of the day, there's going to be stasis because there's going to be impairment in drainage of the lymphatic fluid. So start pulling after about 9 months to 1 year. And I start seeing that the person is developing elephantiasis. So this is actually due to mosquito. This is mosquito effect. Mosquito bite, introduce Wuchereria bancrofti, introduce Brugia malari or Brugia tumori, any one of them, and there's inflammation of the lymphatics, and there's impairment in the drainage of the lymphatics, so leading to the swelling. So don't forget, it is the effect of mosquito. Loasis is the effect of deer fly, mango fly, horsefly. Onchocerciasis is due to the effect of what? The Simulium blackfly. So you treat both loasis and Wuchereria bancrofti with what? Diethylcarbamazine. Onchocerciasis is always treated with ivermectin. So let us see some questions here. And this is a 26-year-old woman who comes to the physician because of fever and right leg pain and swelling for 3 days. 2 weeks ago, he had a short episode of abdominal pain and diarrhea that resolved without treatment. He's an avid hunter and went hunting for a white boar with his father 3 weeks ago. He took some of the meat home for consumption. Temperature is 36.6. Examination shows perioptal edema and conjunctival hemorrhage. Palpation of the right calf elicits tenderness. Range of motion of the right ankle is restricted by pain. Sample of which of the following is likely to show the causal organism? Anybody?
I'll go for blood.
Trichonella spiralis.
I'll go for blood. Trichonella spiralis.
So if we
From
are
wonderful
going for
people.
Trichonella spiralis, so what's
Mhm.
the source?
Yes,
The periorbital edema and the
the source is
conjunctival
the meat.
hemorrhage.
Yeah.
The source is the meat.
So what are we going to pick as answer now?
Muscle.
That should be the
muzzle.
Okay,
muscles.
muscle. Sorry, muscle.
Yes, the muscles.
So there is a periorbital edema here. We can see that
Mhm.
I have conjunctival hemorrhage too, and this guy is complaining of calf pain. That's because that's where
Yeah.
that's where the guy is
My
hiding.
myositis.
You know,
Myositis.
Myositis.
we can see the intestinal manifestation too, having the abdominal pain and the diarrhea. So we have to connect them together. There has to be some intestinal manifestation, which is the abdominal pain and diarrhea. You can see the muscle problems, which is right calf, tenderness and leg pain. You know, we can see the infection, and we can also add the periorbital edema. So everything is just on point. So we are going to give this person the bendazole, and the person is going to be fine. A 38-year-old man comes to the physician because of
Sorry, please, sir. Can you show the question again? Sorry. Okay. Thank you.
You're welcome. So a 38-year-old man comes to the physician because of 2 weeks history of abdominal pain and itchy rash on his buttocks. He has fever, nausea, and diarrhea with mucus too. 1 week ago, the patient returned from Indonesia where he went for vacation, and physical examination shows erythematous serpiginous lesions located in the perianal region and the posterior thigh. The leukocyte is 9,000 with 25% eosinophils. Further evaluation is most likely to show which of the following findings.
X on tape.
X on tape test.
So that is it. So I know that many people are going to fall victim to the question, but we did not pay attention to the fact that they said there is an erythematous serpiginous lesion.
Yeah, and the age. The age.
And the age.
And the age. Just like somebody mentioned. And the age. So it's a very tricky question.
Yes.
So what do we think this was happening here? Erythematous
That should be the
serpiginous
hookworm.
lesion. In
It's
the perianal.
Hookworm.
No, it's not hookworm.
Newcastle, America.
It's not hookworm. Because
Ascaris.
this person is having
It's-
fever, nausea, diarrhea, or mucus too, number one. The location of the what's it called? The rash is at the perianal region. For hookworm, most of the time it will be in the legs or maybe extremity. The perianal region is very slim. And this person is also having abdominal pain and what's it called? Diarrhea with it. So there's something else I can present this way. So what's that?
Third one.
So
Is that the whipworm?
if we're having a serpiginous rash and it's not hookworm, which other one penetrates the skin? That is strongyloides until otherwise proven. So
Strongyloides.
I think I made a mistake. I should have told us that sometimes we can have the worm penetrating, coming out of the anus and entering back. So sometimes they come out of the anus and they can gain entry back through the anus because they penetrate the skin. So they proliferate, there they form their larva, they enter back to the anus and start causing the infection again. So that's why this guy is actually strongyloides. And if this is strongyloides, what are we going to be picking?
A. Rhabdomyform larva.
Rhabdomyform larva.
That's A.
Exactly. So if someone doesn't even know that it's strongyloides and the person thinks it's hookworm, I'm sure the person will have even still gone for the larva on this stool microscopy.
Yes.
So that's just the catch here, the serpiginous lesion. You know, what's it called? Enterobius vermicularis will not cause that. Okay, that's the one I have. Okay. So moving on to the cystose tapeworm, 2 forms. The tinea solium is the first one, and it has 2 forms: the intestinal tapeworm and the cysticercosis. So we have to be careful here. These are not places that they like trapping people. So there are 2 forms: the intestinal tapeworm and the cysticercosis. Cysticercosis is more like the cyst causing a problem. The cyst in the brain, the cyst in the muscle, the cyst anywhere. Cysticercosis. So the common form of cysticercosis is in neurocysticercosis. That's one that is bad. And we have the intestinal tapeworm, so the one that causes intestinal problems. So the mode of transmission is different for the two of them. We have to be very careful. The mode of transmission for intestinal teniasis is different from cysticercosis. So for people with intestinal teniasis, they are getting it from injection of the larva. So they just grab a pork that is not cool, they just start eating it, and the larva becomes released, and it travels to the intestine, develops into the adult worm, and it starts causing the problems. Diarrhea, malabsorption, all those things, leading to, intestinal teniasis. But for cysticercosis, this one, for example, neurocysticercosis, it is not the larva that is staying somewhere. It is it is the larva, but the larva is encysting somewhere outside the intestine. But it does not start from eating the larva. It starts from injection of the eggs. So they take in the egg first, maybe from contaminated food or water, and the eggs hatch into the larva. Then the larva finds its way into the blood and travels to the brain. That's the way it works. And travels to the brain and encysts in that brain. So once you are seeing somebody, the first thing you always want to do, that is how you know people that are actually, are very familiar with all these cystoids. The first thing you must always do when you see tinea is to delineate. Am I dealing with the intestinal form? Am I dealing with the tissue form? So intestinal form is definitely coming from the larva. I have to have ingested the larva. For the cysticercosis form, I have to have taken the eggs. It is the eggs, and the treatment differs a little. So if it's the intestinal form, just give praziquantel. If it's the neurocysticercosis, give your praziquantel, to eliminate the one in the intestine, and add albendazole to eliminate, the one in the brain. Albendazole and praziquantel. Now, so don't forget to, please, we should not forget cystoids, praziquantel. The tissue filaria from diethyl carbamazine, Loasis, diethyl carbamazine, Okosaka, ivermectin, Toxocara, benzazole. But our cystoids, it is actually praziquantel. And don't confuse this with parental palmoate, which is used by hookworm and pinworm. So praziquantel is different from all those things.
Dr. Babawale, bendazole is different from albendazole, isn't it?
No, albendazole is a type of bendazole. So when you say bendazole, it's a class. Albendazole is part. Mebendazole is part. Mebendazole is part. Albendazole is part. I think albendazole is the commonest one that everybody uses. So, so I want to show us an image. So this is the tinea solium. You can see the proglottids here in the neck. And what you are going to see on imaging is just numerous cystic lesion in the brain that is calcified. Once you see numerous cystic lesion like this, tiny lesion, just go and pick neurocysticercosis until otherwise proven. Very simple. Numerous cystic lesion in the brain like this, neurocysticercosis. The next is the Diphallobrotium latum, and that is the fish tapeworm. The fish tapeworm. It means that the person must have gotten the larva from eating a freshwater fish, and this is what it looks like. This is what it looks like. And what do we experience? Vitamin B12 deficit. That is all. It is as simple as that. It's just there to compete with the body for vitamin B12. That's all. Just give you blood work, macrocytic anemia. The person has been swimming in fresh water or something. So what's the cause? Diphallobrotium latum. What do you want to give? Give your praziquantel, or you give your what? Niclosamide. So niclosamide or praziquantel works against these cystoids. Now, the last is the Echinococcus granulosus. Echinococcus granulosus. So Echinococcus granulosus can encysst in the liver or the lungs and can develop an eggshell calcification. So if they say eggshell, there's another place that is eggshell calcification. So if you see somebody having a nodular lesion in the lungs with eggshell calcification, what's the spot diagnosis? Anybody? Silicosis. So somebody having eggshell calcification in the liver or the lungs, you think about maybe in the liver, without any risk factor for silicosis there, so that I don't get people confused. Think about Echinococcus granulosus. Most of the time, they will not actually put it in the lung; it will be in the liver. So because it's a very close differential for entamoeba histolytica. So it's gotten from people that it's gotten from injection of eggs in food contaminated with the dog feces. So it's transmitted by dogs. Echinococcus granulosus is actually from dog feces. If the dog feces find its way into the food and somebody takes it in, its eggs can hatch into the larva like this, and they can cyst somewhere in the liver and lead to hydatid cyst. So the hydatid cyst can cause a very bad problem. They can rupture. And it can lead to anaphylaxis. So maybe suddenly somebody develops abdominal pain, and there's feature of anaphylaxis. You have to know that that is actually the Echinococcus granulosus cyst that has ruptured. So this is the eggshell calcification that we're going to see, and this is also the cyst in the liver. You can see how big it is, so it can rupture. So you have to be very careful. If it's complicated, that is, you are seeing cystic mass, you are seeing solid mass, like that, you have to do surgery. But if it's not like that and it's just mild, you can just give albendazole and treat it. So moving on to the what's it called? To the cystodes. Sorry, I said cystodes, trematodes, flukes. So we're almost done. We have schistosoma and the Clonectis sinensis. So what's it called? So yeah, schistosoma is two types. We have the intestinal form and the blood and the urinary form. The intestinal form and the urinary form. So the urinary form is called schistosomal hematobium. So we call it schistosomal hematobium for the urinary form. And how you identify it is that the location of the terminal spine is central. So there's a terminal spine here. You see it here, terminal spine. While for the intestinal form, which includes schistosoma mansoni or schistosoma japonicum. So mansoni, japonicum, they are like intestinal form, while the hematobium is urinary form. And the what's it called now? The intestinal form has a lateral spine, not a terminal spine, but a lateral spine. So once you see this, okay, this is the head of the intestinal spine. This is the head of the intestinal, type rather. When you are seeing the terminal spine, you know that this is hematobium, which is classic for the urinary type. So what is the problem with respect to the intestinal stuff? The first thing you must always remember is that they have a potential to cause chronic granulomatous inflammation of the liver and the spleen. That's it. So the individual is going to be having hepatosplenomegaly in response to the eggs being deposited. The inflammation can also get to the portal vein, and they can have inflammation, fibrosis of the portal vein, causing portal hypertension. They can also find their way into the intestine, causing intestinal schistosomiasis, in which the person is going to be having diarrhea, abdominal pain, iron deficiency, anemia. So for the hematobium, the eggs just travel to the bladder, and they cause irritation of the bladder, and that's going to lead to what? What change do we expect when there is irritation of the bladder epithelium? What change do we expect?
Metaplasia.
We expect a squamous cell metaplasia, and from there it progresses to what? Squamous cell carcinoma. Don't ever forget squamous cell carcinoma from schistosomal hematobium infection. And at the end of the day, part of the manifestation of carcinoma is that they are going to be having painless hematuria, which can be total, or terminal, but most of the time it will be like painless hematuria. And sometimes the eggs can disseminate into the vessels of the lungs, and it can cause some form of granulation, granulomatous inflammation in the vessels of the lungs, causing pulmonary hypertension. I know that Dr. Babainde will have taught us the classification of pulmonary hypertension, the idiopathic type, what's the mutation responsible for the idiopathic type of pulmonary hypertension? Anybody knows? So bone morphogenetic. Fantastic. So then we look at the ones that share with the heart, the lungs, the heart, the thromboembolism, and the other ones. So now under the class 1, we can also have this pulmonary hypertension from schistosomial heads. So they travel like that because inflammation of the pulmonary vessels and there's obstruction leading to pulmonary hypertension. So always have that in mind. You can see it in your exam. Many people do not know that can happen. I'm saying it here, that can happen. So have it at the back of your mind that schizophrenia can cause pulmonary hypertension. So how is it transmitted? Snails. The snails contain the cercaria, and the freshwater snails can release these cercaria, and the snails like the Bamphilera snails, we don't have to know all those names. They are not going to be tested at all. So just know that it is snail, and the snail will release the cercaria, and the cercaria can penetrate the skin of someone that comes in for swimming, and from there the cercaria enters into the bloodstream and they mature into all these schistosomal adult flukes, and they start causing problems. So just like the cystodes, we also treat them with the praziquantel. So you give all the flukes praziquantel, very easy. The next is cloniosis sinensis. Many people don't put too much mind to it, but it's very important. Cloniosis sinensis is also a type of fluke that affects the bile duct. So they cause bile duct inflammation. And one of the problem or part of the consequence of bile duct inflammation is what? Formation of pigmented stone. So stone that contains calcium, bilirubinate. So they become formed in the bile duct because of the stasis, and because of the chronic irritation of the bile duct, they are associated with forming cholangiocarcinoma. So cholangiocarcinoma is the cancer of the gallbladder, true or false?
True.
True. Bye.
So
No,
from
No,
I think it's the bowel
biodots.
ducts.
Biodots. That's biodots.
Yeah.
so
It's
there's
bile
a
duct.
catch there. So it is cancer of the bile duct. So don't pick cancer of the gallbladder. So the cancer of the gallbladder is called cancer of the gallbladder. No something carcinoma. So but once you see cholangiocarcinoma, that is
Bile
cancer
duct.
of the bile duct. So just like what we are saying now, we said there's going to be biliary tract inflammation. So that means that it is the biliary tract that will develop the cancer at the end of the day. So cholangiocarcinoma. And don't forget what we mentioned that day. People with primary sclerosing cholangitis also have a high risk factor for having cholangiocarcinoma. So it's gotten from consumption of undercooked fish, unlike this one that is like entering fresh water containing snails. But for cloniosis sinensis, they have to eat this undercooked fish and release this fluke. Now, people that eat some form of undercooked fish can also develop which other type of cystodes?
The Latin.
The latin. So let's look at this quickly.
Dr. Baba, well, let me say the people that are at risk of getting the cancer of the bile duct.
Yes, people with primary sclerosing cholangitis. Primary sclerosing cholangitis.
Okay. Thank you.
You're welcome. So a 40-year-old woman with HIV infection comes to the emergency department because of a 4-week history of progressively worsening fatigue and headaches. Temperature is this 38, and on mental status examination, the patient is somnolent and oriented only to person. So this guy is just sleeping. This guy is fatigued and having headache. The CD4 count is 80. Analysis of the CSF shows leukocyte count of 30, and 60% of it is lymphocytes, a protein concentration of 52, and a glucose concentration of 37. An Indian ink state of the CSF is shown. Do I have it? Okay. Which of following is the most appropriate chemotherapy? I think we already know the spot diagnosis already. Why did I even bring this question? This question is too easy. So what's the treatment?
Amphotericin B.
So what is the source? What's the source of the organism? Anybody knows?
Pigeon.
Huh? What's the source? Anybody knows? Immune suppression, yeah, I agree, but what can somebody get exposed to?
Is it from pigeons droppings?
Yes.
Pigeon
droppings. Yeah, pet droppings. Pigeon droppings. So Moving on to the ectoparasites. So we have three of them. Sarcoptes. Scabies is number one, and we know it very well. Scabies is very simple. Everybody knows scabies, and it's like a mite that burrows into the skin, stratum corneum, and cause pruritus, which usually worsen at night. And you see the burrows in the intratuginous areas of the hands, fingers. You see them burrow, into it, and it's very common in children or people that live in a crowded, unkempt area. So usually like skin to skin contact, or using formites. So if you are sharing like towels, clothes, all those things. So how do we treat? We just apply the parenteral like permethrin cream, or can give them oral ivermectin. So oral ivermectin that is used in treating onchocerciasis can also be used in treating Sarcoptes, scabi. So, and after you have washed the person and we have prescribed the cream, we have to encourage the person to try and wash all their clothes and at the same time iron all their clothes, and beddings. So the next is the pedunculus humanus or the feturous pubis. So this is just the louse. So we have a louse or the lice. Which one is the plural? Is it lice that's the plural or the louse?
Lice is
Like,
plural.
Lice is
Lice is
plural,
plural. So
louse is
louse.
singular.
So the blood-sucking lice that cause intense pruritus, and it's actually with excoriation because they're always itching, they're always scratching. It's pruritic. So we have three forms: the ones that affect the head, the ones that affect the body, and the ones that affect the pubic region. So people having this pruritic scratching of the scalp and the neck usually have the head one, while people that have the scratching in the waist and the axilla, usually in the body, and the pubic region and perianal region, will be the pubic lice. So the body lice, the one that affect the axilla and the waist region, is transmitted by Rickettsia prowazekii. And we said that this Rickettsia prowazekii causes epidemic typhus yesterday. So which one causes Rocky Mountain spotted fever?
Rickettsial, rickettsial.
So the Rickettsia, and we expect triad of what?
Rash
The
on
hard and
ankles,
foot rash.
rash
Yes. So how does the rash start?
from the ankles and
Yeah.
finger go
To the wrist to the ankle.
to the
Exactly.
wrist.
So it starts at the ankle, start at the wrist, then move to the
Yes.
distal part. So distal part of
Yes.
the ankle is the sole, distal part of the wrist is the palm. And from there, they move outwards like that. And the person is going to have a triad of the fever, the headache, and the rash. And they can have some petechiae, lesions, as the rash. Because the cause of the rash is the what?
Vasculitis.
So
Vasculitis.
give them which drug?
Oh,
Give
doxycycline.
them
Doxycycline.
doxycycline. So so the other organisms that can be transmitted by these body lice aside Rickettsia prowazekii includes Borrelia recurrentis, which causes relapse in fever, and Bartonella aquintina, causes string fever. So that was not important. We should know the treatment. What are the treatments? Just like scabies, we also use the parenteral like permethrin. We can use malathion. We can use ivermectin too, just like what we give in people with scabies. Give them ivermectin, give them parenteral. Make sure you comb their hair. Why? Because if you look at their hair, for example, people with the head lice, you see the hex, which we call the knit there.
Mm-hmm.
So once you are seeing this knit, this is the pedunculus humanus until otherwise spoken. That's the louse. The person is dealing with. So always comb their hair to remove the knit, and you can treat them without stopping them from going to school. So the last is the Cimex species. Cimex lenticularis or Cimex. I don't care what it is. Just know Cimex, and they are called the bed bugs. And they don't really cause any specific illness, but they just feed on the skin, and they are blood sucking, and they are very common in areas that are congested, that are unkempt, that are places that they don't wash the beddings, so unwashed beddings, congested, infested hotels or rooms, like that. So they usually have a lot of bed bugs there, and they cause we call them morning, night, morning, afternoon, dinner, something rash. I've forgotten the name now. But the bite is usually painless, and you see a patterning. You see a pattern. You can see like one bite here, and that bite here, and that bite here. So that there will be some patterning to the rash, to the bite, and it's usually pyrrhitic, but it will be painless. You will not even know that it has, the bug has bitten that person. And we can appreciate the presence of the papules, which will have a central hemorrhagic punctum. So that we might need to have a look. Bed bug rash. Cimex. So this one is a very good example. So you see 1 year, under 1 year, under 1 year. See 1 year, 1 year, 1 year, all those kind of things. So there'll be some patterning. So you can see the central hemorrhagic punctum in this one. Can we see it? Is it evident? Yeah. So that's the central hemorrhagic punctum. So they usually have a clustered or a linear pattern of the bite, and the only way you can make the diagnosis is look for those bed bugs. Look for them and clean the room, wash the beddings, and apply the insecticide to eliminate the bugs. That's it. You have to eradicate the infestation. That is the mainstay of treatment. So we have some associations and some organisms that we have to be very familiar with. That's why it's listed here. Biliary tract problems and cholangiocarcinoma, we said that is particular to chronitis. And how is it gotten? Chronitis, how is it gotten?
Undercooked fish.
Undercooked fish. So the brain
Fish.
cysts and seizures. Brain cysts and seizures is what? Tinea solium. Neuropsychosis. And injection of what? Injection of the head. So hematuria and squamous cell carcinoma of the gallbladder, of the bladder. So that's going to be schistosoma, hematobium. That can also cause what? In addition to bladder issue, can also cause what?
Pulmonary hypertension.
So the liver cyst, and exposure to dogs is what? Echinococcus granulosa, which you treat by, giving what? What do you use to treat it? Albendazole. So iron deficiency anemia can come from hookworm, Necator, and myalgia and perioptidema is classic for what? Trichinella spiralis. Nocturnal perianal pruritus is what? For enterobius regularis. Portal hypertension is always for the schistosoma Mansonia. Japonicum. That will have what type of spine?
Lateral.
But ambiguous to efficiency. Good job. Oh my God. So we'll move to the virus. So please, let's just bear with me. We'll soon go for our break. Let's just push this thing, and make sure that we're almost done with it. So please, I'm so sorry. We'll go for our breaks very soon. I know most of us, we are tired, but please just bear with me. Let's just push it a little bit more and we go for our break. Then I think we are going to meet later in the night. So we just, I think so that we can just round it up. So the virus. Okay, I think I have some questions. Don't let me miss that. I think I have some questions here. And this is the ectoparasites. So a 17-year-old girl is brought to the physician because of 1 week history of severe itching in the areas of her genitals. She reported that the itching is most severe at night. She's sexually active with 3 partners over the past 1 year. She uses condom for contraception. Partner too is experiencing similar syndromes. Pelvic examination shows vulvar excoriation. A photograph of the epilated pubic hair is shown, which of is a causal organism. What do we think? Until otherwise proven, what is this?
Maybe Cimex.
This pubic lice.
Yeah, pubic lice. Why did somebody say Cimex again? Somebody was saying Cimex.
That's that book.
So you can see the
looks like
the louse.
Yeah. So that's the louse. That's a louse. So that's a pubic what? Pubic what? Yes.
Humanus.
Pubic
Manus.
no, pedicus humanus is the head one. I think pubic features.
Is the pubis.
Yeah. Features pubis. Yes.
Yes.
Okay.
But Laos. So I think it's the only one that is there.
What is the question? Okay.
I think it's the only one that is there. So
Is the humanus? Okay,
the,
pubis is
the
there.
pubis. Yeah, so sorry. I've even forgotten that the option is pubis. Yeah. Pubis. So so moving on to this. A 61-year-old man comes to the physician because of 5-month history of sharp shooting pain in the legs. 21 years ago, he had a painless ulcer in his penis that resolved without treatment. There's no history of serious illness. Examination shows small pupils that constrict with accommodation but not to light. What is that? Until otherwise proven. What?
Agent Robertson's
Robertson pupil.
So
So
sensation to pinprick and light touches decrease over the distal lower extremity. Patellar reflex are absent bilaterally. His gait is unsteady and broad-based. This patient is at risk of which of following complications? What's our diagnosis? Specific. Sorry, I want us to give me like specific diagnosis. What is the specific diagnosis?
Tertiary stage.
This is tertiary syphilis.
Tertiary syphilis.
So what is the complication we expect?
I think I'll go for thoracic hernia.
Aortic aneurysm.
Fantastic job. Fantastic job.
Aortic.
Very
Sorry,
simple.
how did we know that it was tertiary syphilis?
So this man had, although they usually have the shooting pain, but we don't talk about it, so let's ignore that. This man had a painless ulcer in his penis 21 years ago. 21 years ago. So that's a primary chancre, right? Now he's now having small pupils that constrict with accommodation, but not to light. So that's Agee-Robertson pupil, which is one of the neurologic complications of what? Syphilis. And now he's also having some other neurologic stuff like sensation to light touch being decreased over the distal extremity. He's having problem with the patellar reflexes, and most importantly, the gait is unsteady and broad-based. So that means that there's already affectation of dorsal column, tabes dorsalis. So this is tertiary syphilis because there's affectation of the new nervous system. So if it's already getting to the nervous system, it is tertiary. So what are the features of secondary syphilis? Anybody remembers?
Generalized
condylomata lata. What else?
Generalized lymphadenopathy.
Generalized lymphadenopathy. What else? So what's the characteristics of the rash that we said?
There is
On the palm and so.
Yes. So the rash is maculopapular and it extends to the palms and the soles. So very important stuff. So the patient is going to be having fever, generalized lymphadenopathy, maculopapular rash, the condylomata lata. You can say that, okay, this is secondary syphilis. So moving on to the viruses. The viruses, they're a little bit confusing. We have a lot of organisms to be palming, but the most important thing is just to know the genetics, which is very simple, and know the specific organisms and what they cause. That is it. Most of all these helical capsid, they will not really ask what does it cause, what is that organism, and the genetics. That is it. So, but a typical organism can be naked, in which that it does not have any envelope, which is docked with the protein. So all it has is the capsid, surrounding the nucleic acid. This is a naked organism. But sometimes they can be covered and they are no longer naked when they have the envelope. So in addition to the capsid and the nucleic acid being surrounded by the capsid, we have the outer envelope, which is docked with several surface proteins. And the genetic material, or the capsid rather, can take different shapes. You can have the icosahedra as well as the helical. So you can see that the helical is just straight, and the icosahedra is kind of pentagonal or polygonal. And of course, we have this guy. Do we remember this guy? What is this?
Bacteriophage.
Yeah.
You know, if you remember that day, I said it's a virus. You know, it's a virus that infects bacteria. So this is a bacteriophage.
Bacteria.
So viral genetics, this is just talking about the genetic interaction between the viruses, how it can happen. So the first is recombination. Recombination is just where you have exchange of genes between two chromosomes. So that means that you have virus 1, virus 2, virus 1, virus 2, and they want to interact together. So what they do is that there's going to be crossing over between genes that are of similar homology. So meaning that maybe the base sequence here is very similar. Maybe they have BBC here, then there's BBB there. So they tend to exchange their materials between that two similar sequence, and that is all. So if you look at this point now, this point and this point is said to be similar. That is why when we get the exchange, we are seeing that there's an overlap between blue, green, while this place still remains to be blue. So because the only region where we have homology similarity is between this 1, 1 and this 1, 1. That is all. Do you understand? That's recombination. So just recombine where you find similarity. Do we get that?
Can you take it again, please?
So in recombination, there is recombination of gene in area where there is similarity in the base sequence. So if there's similarity in the base sequence of this part, this part, and this part, it is going to interact with another portion where there is similar base sequencing, maybe this part and this part. So that is why when you get the interaction, the crossing over, you see that there's a mix here, but this part remains to be blue. Do you understand that? Hello?
Yes.
So just know
Yes.
that the recombination is happening exactly. It doesn't go more than that. It's not as complex as that. The interaction is happening in area where there is similar base sequence. That is the recombination. It's not more than that. For the reassortment, all you need to know here, number one, is that before you can pick reassortment as your answer, you must ask yourself one question. Are the organisms involved what's it called, segmented in terms of their genomes? You can never pick what's it called, reassortment for organisms that don't have a segmented genome. I will come to the acronym BOA later. So the Bunya family, the Automyxo, the Arena, and the Rio. So Rio like rotavirus, Arena like Lassa fever, Automyxo like influenza. And so any of these organisms, because they belong to the family of BOA, they have segmented genome. So that means that they can undergo reassortment. That is why the commonest organism that they usually use to explain reassortment is influenza, because it belongs to the family of the Automyxo. The Automyxo, which has a segmented genome. So we'll talk about the Boa, the Bunya, the Automyxo for the whole, the A for the Arena, and the R for the Rio. So the Rio includes Rota, the Arena includes Lassa fever, the O includes Automyxo like influenza. So the Bunya contains some family of Candida we don't, they are too complex, we don't need them. So now, after we have established that fact, are you segmented? Meaning that you have segments in terms of your genome arrangement. So if you look at this one, this is the first segment, upper segment, lower segment, upper segment, lower segment. So it means this guy is segmented. So that means that this guy can actually undergo what's it called? Genetic reassortment. So genetic reassortment means that you are just sorting the genes. So you bring this one, and you bring this up, and you bring this one down. That's all. You know, you can create another strain that is going to be having this one up and this one down. Do you understand? Do you understand that?
So, doctor, they both of them has to be segmented, correct?
Yes, they have to be segmented. So to produce one progeny, you can take the upper part of this one and the lower part of this one. To form another progeny, take the upper part of this one, take the lower part of this one. So that means that your progeny will always contain gene from this and this. Same with recombination. The progeny is
I
always
was going to say, so same with recombination, except that in resortment, they're segmented.
They're segmented, and you always have to state the fact that in recombination, the homology is only taking place at the area where you have base similarity, base sequence homology. Very, very important stuff. So now, what is the implication of reassortment? Reassortment is the reason why we can have antigenic shift, which is a bad problem. So in 2009, we have this novel, hemagglutinin-1, neuraminidase 1 influenza, because we had a pandemic which emerged from that due to like a complex viral resortment of gene between the human influenza, the swine influenza, and the avian. So what happened was that there was reassortment between influenza virus that infect human. This one infect human, this one infect bird. They interact together, they share their gene, they get this. This one now interact again with the one that, affect birds or swine. Swine is pig, so let's say swine, and they resort that gene. So that means that we're now having a product that has some genetic material from the one that can infect human, the one that can infect pigs, and the one that can infect avian. Now, I want to ask us, do we think there's anybody in the world that is going to have a T cell that can respond to that product in the world? Do we think there's anybody that's going to have a T cell established to attack that kind of product? Do we think so?
No.
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 So that is why
No, because they form new virus.
Yes, that's a new genome completely. So that's why there's going to be a pandemic. That's why we have the corona pandemic, because probably what we are getting is something we have not seen before, ever. So that's why there's going to be a pandemic. So that's the difference between antigenic shift and antigenic drift. Drift is still milder to shift. Once you have shift come out, there's a problem. But for drift could just be like small mutation, maybe mutation in maybe the surface protein. That's all. It's not really affecting the entire genome. Maybe surface protein just get mutated. That's it. Some people will still be able to respond to it. So it will just cause more like an epidemic, not a pandemic. So you have to know the difference. Moving on to complementation. So complementation is very simple, because here you are not really exchanging any genetic material. You are just helping a cell that's incapable of infecting a cell to be able to infect a cell. And the very common example that we use is interaction between hepatitis B and hepatitis D. So, what I'm saying is what we should pay attention to. Please don't disturb yourself and be reading the story, because you would lose track. So what I'm trying to say is a summary of what is said here. So we have a functional cell. Let's assume this is hepatitis B that has its genome here, and it has a protein coat, the capsid, intact, and it is functional because it can infect a cell. But hepatitis D doesn't have, a capsid that is functional to infect a cell. So hepatitis D is always dependent on hepatitis B to infect a cell. It is always dependent on hepatitis B to infect a cell. So what is going to happen? And I have to mention to us that what determines tropism, that is the ability to infect a particular cell, is the nature of the capsid coat, not the gene per se. Although the gene is going to encode the protein that is going to form the capsid. Do you understand? But it is the capsid that virus is carrying at that time that is going to determine the cell it's going to infect. Does that make sense to us? So what will now happen is that hepatitis D will now come to hepatitis B that, brother, please, I want to be flenjoy, like I want to be infecting all these hepatitis and be playing now. Please help me. So hepatitis B will now come out, no worry, brother, be my guy now. And it will release its capsid coat and give it to the hepatitis D. So you will now notice that the product will now become functional, because even despite the fact that it is still retaining the genetic material of the hepatitis D, it's already been covered by the protein coat of hepatitis B. So this is complementation. I'm just complementing you so that yourself, you'll be able to stand alone. That is what they are saying. Do you understand that analogy? Is it clear to us?
Yes.
So
Yes.
so never make the mistake of picking exchange of genetic material. Have they exchanged genetic material here?
No.
So always be careful. Understanding is what the USMLE will test you on. So the next is what? Phenotypic mixing. And in phenotypic mixing, it's a little bit similar to like this complementation. So you have like two viruses infecting a particular cell. So now what will happen is that you are going to have a first progeny in which you have like a transfer of the what's it called, the protein code of one virus to another virus. So for example, because I want to make virus A although both of them are functional, so that's the first thing I have to say before I go ahead. In phenotypic mixing, both of the viruses involved are functional. In complementation, one is not functional, the other is functional. So one is helping the other one. Now, in phenotypic mixing, both of them are functional. But the reason why these guys are coming together is that virus B, so that I can follow this image. Virus B is coming to virus A that, guy, I'm just infecting some specific hepatocyte. I want you to give me something that I can use to attack maybe kidneys. I want to go to the kidneys. Like, I like that area. I'm not satisfied with this hepatocyte. So what will A now do? It will be like, don't worry. I know that you have enjoyed this liver, and you are happy. Okay, don't worry. I'm going to give you something that would make you go to the kidneys and go and taste good life. So virus A will interact with the virus B, and it's going to release sorry, I think I have made a mistake in my analogy. Let me go again. Let me change it again. So the one that is enjoying the good life is virus B. So virus B is the one that is satisfied. It has the ability to infect the kidneys and the liver. Virus A only has ability to infect the kidneys. So virus A wants to be able to infect the liver too. So what would virus B now do? Virus B will now come and interact with the virus A and give it its protein code. So we are forming progeny 1. So progeny 1 is containing the genome of virus A, but the protein code of virus B, so that it will have ability to what? To infect both the kidneys and the liver. Please, do we get it up to that level?
Yes.
Eh?
Yes.
So
Can you take it again?
some people are still saying we should take it again. Now, let me start again. Virus B has the ability to what? Okay, so let me use this USMLE. Virus B has the ability to pass USMLE step 1 and 2. Virus A only has ability to pass step 1. Now, virus A needs to progress to pass step 2. So it now comes to virus B that, bro, please, can you help me? I need to pass step 2. Now, you remember that both of them, they're actually functional because they can both pass exams. Virus A has passed step 1. So it's not as if it's handicapped, it's functional. Virus B to have passed step 1 and step 2. But virus A just needs little help to pass step 2. So what is going to happen? Virus B will now be like, there's no problem, bro. We there for each other. So virus B is now going to release its brain, which is going to be this capsid, and it's going to give virus A. So the progeny that is going to go for that exam is going to look like this. The gene for the virus A, but the protein code, which is like the brain of virus B. Do we understand that?
Yes.
Now, let me now ask us this question. If this progeny undergoes DNA replication and it wants to replicate itself, because of the fact that it still contains the genome of virus A, do you think that when it replicates, it's going to maintain the capsid code of virus B?
No.
No, because this capsid code is a protein, and it is whatever DNA that you have that will determine what protein you would produce. So that means that if progeny 1 replicates, it is going to lose the ability to pass step 2. Do you understand that? It is going to lose the ability to pass step 2 because it no longer contains the protein code of progeny the progeny 1 or that of virus B. That is it. So what they are going to give you in the exam, I'm sorry I don't have a question here to justify that, but maybe I'll look for one later. And you just notice that they will tell you, very simple, they will just tell you that the virus interacts and After that interaction, one of the virus acquired a function, a new function. But they will not discover that when that virus now replicates, the next generation lost the ability. What is your answer on the otherwise problem?
Maybe phenotypic mixing.
Phenotypic mixing.
That is how you are going to see the question in your exam. It is as simple as that. But most of the time,
the questions again, please.
So, Dr. Babawale, what they're exchanging is the capsid, not the DNA.
What they are exchanging is a capsid, not the DNA. So I said 2 viruses interact with each other, and one virus acquires a function, an extra function. Now, the product of that interaction, which is the new virus that acquired that function, replicates, and it was noticed that the next generation, the subsequent generation from that progeny lost that ability, that new function. They lost it. Do you understand? So this guy and this guy replicate. They give birth to this guy, progeny 1. Progeny 1 is very brilliant. But they noticed that when progeny 1 replicated to give new generation, the intelligence is lost. That is phenotypic mixing, because they are just mixing the phenotype. They are not mixing the genotype. Genetics is what is responsible for the intelligence, not the phenotype. Do you understand? So that is the way it works. So,
but Dr. Babawale, I think it's similar to complementation. So how can we differentiate it?
So that's why I said when we are going to be starting complementation, they would have already told us that one is functional and the other is what? Non-functional. In phenotypic mixing, both of them are functional. One just needs help to augment. And most of the time, the interaction for complementation is usually interaction between hepatitis B and hepatitis D. You will see it like that. Hepatitis B and hepatitis D. Hepatitis D cannot survive without hepatitis B. It cannot. So I think I have a question here. Okay. So an investigator who studies virology obtains a biopsy from the HOSA base of an active genital herpes for viral culture. The cultured virions, along with the epic simplex virions of a different phenotype, are co-introduced into a human epithelial cell in vitro. The progeny virus are found to have phenotypes that are distinct from the parent strain. Sequencing of this progeny virus show that most genomes have material from both parent strain. This finding are best explained in the following terms. Let's just study it well and understand it and pick the answer.
Reassessment.
So what is our agreement when we say before we pick reassortment? What are we going to check for? Because some people have forgotten already. We are going to do what?
Segmented.
So we are going to check
segmented virus.
And don't forget, I gave us the acronym BOA. So I said it's either orthomigravirus, which is influenza, it is arena, which will be like Lassa fever, or it is real, which will be like rotavirus. Did we mention episimplex?
No.
It's a recombination.
That is recombination.
Recombination.
That is recombination until otherwise proven. That is recombination until otherwise proven. Okay. So, well, we've not done this, but let me just see if we can try. Like we've not talked about the nomenclature. That's what I mean. But I'm sure we understand what is going on here. So, a 29-year-old woman with a history of intravenous drug use is brought to the emergency department because of one-day history of fatigue, yellow eyes, confusion, and blood in her stool. She appears ill. The temperature is 38.1. Physical examination shows pain in the right upper quadrant with diffuse jaundice and sclera icterus and bright red blood in the rectal valves. Further examinations demonstrate virus in her blood, some of which have a partially double-stranded DNA while others have a single-stranded RNA genome. This question should not be here. They are found to share an identical lipoprotein envelope. They are found to share an identical lipoprotein envelope. This patient is most likely infected with which of the following pathogens? Anybody knows what is going on here?
Is it hepatitis
Is
B?
it D?
Hepatitis B.
Yes.
Hepatitis.
B.
So this is
Hepatitis.
this partially
Hepatitis.
double-stranded DNA is hepatitis B interacting with hepatitis D.
Hepatitis.
And they notice that they share an identical lipoprotein
Yeah,
envelope.
and
So that's the capsid that they are sharing.
That should be
So that's
That's
going to be.
D.
So that's going to be.
D for dog.
No, which
That's
one is it? 1,
hepatitis
2, 3,
D.
4. Philo.
No.
No.
So what we've not done. Don't worry. I just want to test that we understand what's going on.
Happy virus.
No, it's not
Happy
epi.
virus.
It's not.
Thank
It
you.
is.
I
It
was
is
thinking
delta.
maybe it's vitamin D.
It is delta
Hepatitis
virus.
D, sorry.
Okay.
Yes, Delta virus.
It is delta virus.
Hepatitis D. Yes.
So it's under the delta virus family. So that's just. So that is complementation that they are testing there. That's complementation. So moving on to the viral genomes. This part is a little bit tricky. We just try to explain it. I'll try my best to explain it. Please let us pay good attention. So, naked nucleic acid of most double-stranded DNA viruses, except pox and HPV, as well as positive strand single-stranded RNA, are infectious. So, what they are saying here is that we have double-stranded DNAs. This marker, I wish I can just write on the screen with my hand. Double-stranded DNA viruses and the positive sense single-stranded RNA viruses. So now they said the nucleic acid of most of these double-stranded DNA viruses and the positive strand sRNA virus are infectious. So for a virus to be infectious, we must be able to convert this DNA to mRNA, and the mRNA must be converted to protein. It is the protein that is going to be forming the weapon that the virus will use to cause trouble. True or false? True. So same thing for this RNA. You must be able to convert it to protein. You must be able to transcribe it, or translate rather, to translate it to protein. Now, you need enzymes to do all these things. For DNA, I need like a DNA. What do you use to convert DNA to RNA? DNA-dependent RNA polymerase, right?
Polymerase, yes.
So you need a DNA-dependent RNA polymerase to do that, and you need also your ribosome and all that thing to translate your RNA to the proteins. So that's the way it works. Now, there's something I want to say here. Now, most of these cells, if they are affecting eukaryotic cells like human beings, and all these enzymes that I've mentioned, the DNA-dependent what's it called, RNA polymerase, or the machinery to convert RNA to proteins are in eukaryotic cells. So that means that these viruses, if they infect eukaryotic cells, they can easily use the replicating machinery of the eukaryotic cells to complete their transcription to protein and start the infection. Let me come again with the reason why I said that. It's because they are naked. Ideally, if they are covered with the envelope is their duct with proteins. So all these proteins, all these enzymes that they need are always present on the envelope. They're always there. So they don't need anything. But once they are naked, they lose all those proteins. So they will not be able to do anything. But double-stranded DNA and single-stranded RNA viruses will still be able to do something, because they can use the enzyme that is present in the eukaryotic cells to proceed. Do you understand it up to that level? Anybody understand it up to that level? Do we understand it? Okay.
Please come again.
Nobody understood.
Please, I don't understand.
So we have like sorry about that. We have a double-stranded DNA virus, double-stranded DNA, here, double-stranded DNA, and we have single-stranded RNA. So now we've said that they are naked. They are naked because they have lost their envelope protein. Now, ideally, if they are not naked, they'll be able to cause infection. Why? Because they will have their enzymes to convert it to protein. The double-stranded DNA will have its enzyme, which includes the DNA-dependent RNA polymerase, to move it to mRNA. Then they can also use some of those other enzymes to move it from RNA to protein. Do we get? By translation. Do we understand that? And
Yes.
and for positive strand RNA, they can move from this positive strand RNA to protein easily by using the ribosome and all those things in the in the eukaryotic cells. So by using some of their enzymes. What's the enzyme that they use to move mRNA to protein? Do we know any enzyme that they use?
Transcriptase.
So maybe some of those, is it transcriptase now? The process is translation. So some of those enzymes, in the ribosome that they use to move from RNA to protein. But the point is that some of these enzymes are on their envelope, and at the same time, some of those enzymes are also on the eukaryotic cells. We know that eukaryotic cells normally, what they start with is what? DNA. They replicate the DNA, they move the DNA to what? To mRNA, and they move the mRNA to what? To protein.
Proteins.
Do you understand? Do you understand that?
Yes.
So that is a normal process in an eukaryotic cell. So all these cells too, when they are covered, they can also do that because they have those enzymes. So when the double-stranded DNA organism is covered, it has a protein, it has the enzyme to move double-stranded DNA to RNA, and from RNA to protein, it can do it. Single-stranded too, it can move its RNA to protein easily. Easy, no problem. But when they are naked, they are supposed to lose that function because they don't have this enzyme again. Do we get it up to that level?
Okay. Yeah.
But you are now saying that they are not losing it. Why are they not losing it? Because when they infect eukaryotic cells. And we have said that eukaryotic cells already have those enzymes. Do you understand? Eukaryotic cells already have those enzymes. So they can use the enzymes of the eukaryotic cell to complete their translation. And they can form their protein and cause the injury. Do we understand that?
Okay. Yeah.
So that is why we are saying that naked double-stranded DNA virus and single-stranded DNA can still infect. But naked single-stranded RNA that is negative sign and double-stranded RNA that is negative sign cannot. They cannot. So the reason is because if you want to if you want to transcribe a negative sense RNA, you must always convert it to a positive sense first. You must always convert it to a positive sense. You cannot move from negative to protein. It must always get converted to a positive sense. Now, who wants to try? What is going to be the enzyme that is going to be moving a negative sense RNA to positive sense RNA? Anybody wants to try? What is going to be?
Reverse transcriptase.
No, because we are moving RNA to RNA. So it's going to be an RNA dependent or a RNA dependent RNA polymerase. RNA dependent means that you are depending on a starting molecule of RNA. RNA dependent, and you are still moving it to an RNA. So it's going to be RNA dependent RNA polymerase. But do we think that RNA dependent RNA polymerase is in eukaryotic cell? Anybody? Do we think it's in eukaryotic cell?
No.
No. Because which eukaryotic cell is going to be converting RNA to RNA? Are you joking? Why do you need that? So that is why, and this is the enzyme that these guys, they need. But the enzyme is unfortunately not present in eukaryotic cells. So that is why once they are naked and they lose their protein, they will never be able to infect again. Never. Does that make sense to us? So now that is what we are talking about. So because it said here, the variants of the negative strand RNA, they carry the RNA-dependent RNA polymerase to transcribe from negative to positive. They said the variants. Now, when they say the word variants, that means that they are saying they are talking about the complete genome. That is, The viron means the complete organism that contains the DNA, the RNA, as well as it cover the envelope. But once it is naked nucleic acid, it does not, we cannot call that a viron again because it doesn't have any covering, and it will lack the enzyme, the polymerase to transcribe. You understand that?
Yes.
So,
Yes.
so in case they just put it in question, we just be able to maneuver ourselves. So, what are the DNA viruses? So we have a lot of them. I think the acronym is like API or so, but all of them are actually double-stranded DNA. Their genome
Sorry,
is
Dr. Babawale, before you go on, let me just quickly summarize what I understood by what you said. You said naked viruses can never be able to infect any eukaryotic cells because they have lost their protein. Hence, they can't infect cells. In essence, that's what you have explained. And then the negative sense must always combine with the positive sense RNA, either RNA or DNA, in order to be able to infect organisms.
I think there's some little. Okay, I don't
Yeah,
know if there's any. Is there anybody that can maybe help a little
yeah.
to
So
clarify?
the way he said that if it's naked, but if it has positive cells, it can still infect it because the protein that they need, human has it. But if it's negative and naked, they can't infect the human cell because the protein that they need, the human doesn't have it, which is RNA dependent RNA polymerase. Human don't have that. So the negative naked cannot affect it. They lose their code.
Yes, I
Okay.
think that the doctor is correct, but she was breaking a little. So
Yes, so I didn't get her. So please, can you
yes,
come in?
so someone wants to try.
Okay.
Someone else want to try.
Yeah,
Okay.
I just wanted to say the last statement she made. You see, the negative cannot infect. It needs to be converted to the positive.
Yeah.
Okay.
Before, yes, it's
Okay.
not combining, but the
Oh.
negative RNA needs to be converted to positive RNA before it will infect. But unfortunately, that enzyme is not present in the eukaryotic.
Exactly. So that is it. That enzyme, which is RNA dependent, RNA polymerase, because if you are converting from negative ssRNA to positive sRNA, you are still converting from RNA to RNA. So that's why we call the enzyme RNA dependent, starting on an RNA, converting to an RNA. RNA dependent RNA polymerase. You see, what they are converting to will always be the last nomenclature. What they are starting with is always the starting nomenclature. So RNA dependent RNA polymerase, which is not present in eukaryotic cells. So there's no way all these negative strand guys can infect if they are naked.
Okay.
But if they are not naked, they contain their enzyme, they will be able to infect. So that is a difference. Okay.
Thank you, everyone.
Sorry, I have a question.
Okay.
Hello. Sorry. The question I have is, so what makes it positive? Like, what, like,
Yeah,
that's the
so
question I have.
it's the orientation of the I think the orientation of the sequences or so. I'm not really sure, but I think
Okay. No,
that's
I thought it was a special enzyme. Don't worry. Thank you.
the what?
I thought it was a special enzyme. As long as I don't need to know, don't worry.
No,
Thank you.
there's no special. It's just it's just like the orientation of the arrangement of the genome or something. So
Okay,
that
thank
is
you
it.
very much.
But if I check, I would let you know. I've forgotten now. So so the DNA viruses, all of them, they are double-stranded except one, which is single-stranded. So that's like the smallest. All DNA viruses have double-stranded DNA because normally DNA should be double-stranded. Why would DNA be single-stranded? But the only guy that has a DNA that is single-stranded is a parvoviridae, and parvo is high yield in our exam. We cannot go for exam we don't know parvovirus. It is not acceptable. So, and again, all of them are linear because in addition to the fact that you can be what's it called double-stranded, the shape can also change. It can be circular or it can be linear. So all of them are linear except the PP and the partner. So the partner, which is hepatitis B, the papilloma, and the polyoma. So papilloma, polyoma, and a partner, they all have circular, while the other ones are linear. Trust me, nobody's going to be asking us this. But I know that the common one that everybody usually talk about is the fact that a partner have a circular DNA. So maybe we can just, if you don't remember the theory, at least remember that a partner has a circular DNA. So, but don't forget the fact that all of them are double-stranded except the abnormal one, which is the parvo, and it is the smallest. Why the RNA virus all have single-stranded RNA genomes except the Rio. So Rio is the biggest. Rio is the only abnormal one that has a double-stranded RNA, and that's abnormal. RNA should be single-stranded, but Rio, an example of the Rio is Rota. Rotavirus belongs to the Rio family, and it has a double-stranded RNA structure. And don't forget, it also belongs to the family of the what? The Boa. So that means that if this guy is interacting, it can undergo which kind of genetic interaction?
Resolvement.
Resolvement. Good job. So so they are further classified into the positive strand and the negative strand. So I think I have one acronym here. To be honest, I don't think you need any acronym in your exam. I doubt if they are going to be asking you which is positive stranded or something. I doubt it. So I went to a retro toga party and I helped flavor and clean the Pico Coronas. So I just try to just come up with, it's not very easy. I went to a retro toga party. I helped flavor and clean the Pico Coronas. So although it's not very, very important to know if it's positive stranded but I know that some of us might not be able to take our eyes off it and struggle with it and okay, I just want to learn it, but it's not actually important, to be honest. It is not. So under the positive strand, I went to the retro toga party and I helped flavor and clean the Pico Corona. So retro, that's the HIV, retrovirus. HIV is an example. Toga, I'm going to show us later. So Toga will have something like the chikungunya and the other ones. And the party, so that's just to make sense. Help, that's the epi. The flavor, that is the flavi. The clean, that's the calisi. The pico, that's the picona, and the corona. So once you know this, you don't need to cram the other ones. So the other ones are negative. The other ones are like arena, bunya, paramyxo, automyxo, philo, rhabdo. The ones that you cannot forget. You can't forget rhabdo. You can't forget what is in rhabdo. You can't forget what is in auto. You can't forget what is in paramyxo. You can't forget what is in arena is not, nobody actually talks about Lassa. So, but auto, rhabdo, paramyxo, we cannot forget what is there. So generally, envelope virus acquire their envelopes from the plasma membrane. Yes. So now this is also important. When the virus infects a cell, if they want to board off and form new virus, of course they need to segregate. They need to arrange the genome into an envelope. That's the way it should be. So the source of the envelope is usually from the cell they are infecting. They take it from the plasma membrane of the cell they are infecting. So let's say that hepatitis B is infecting a liver cell. So this is a liver cell and this is hepatitis B. So if the hepatitis B attacks the liver cell and is coming out of it, it's going to take new envelope from the plasma membrane of this liver cell. That makes sense. But the EPIs that we're going to be talking about shortly, the EPIs, they acquire their own envelope from the nucleus, the nuclear membrane. They acquire their own envelope from the nuclear membrane, not the plasma cell, not the plasma membrane. Okay, so looking at them one by one, very interesting stuff. The first one we are looking at is at the what's it called, the double-stranded DNA stuff, and no, not the double-stranded, everything in total. These are the DNA virus in totality. So, and the acronym is HAPPY, 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 HAPPY. And the first there is the herpes. So herpes virus is an example of a DNA virus. Herpes virus is an example of a DNA virus, but it obtains its own envelope from the what? From the nuclear membrane of the cell it is infecting, and not from the plasma membrane. So of course it's going to be enveloped. Don't worry about this thing. I'm serious. Don't worry about it. Don't worry. So we are going to look at the herpes one by one and see what is there. Then the next is the pox. That's the next P. The pox. The pox. The pox. The example in pox includes smallpox, but smallpox have been eradicated. They have taken out smallpox a long time ago. So, and to vaccinate against smallpox, we use a live attenuated vaccine. Another example under the pox is the cowpox, which is very common in milk-maid people that do all this milking of the cow. And the third is molluscum contagiosum. I cannot go for exam and not know molluscum. It's bonus point. It's always bonus for everybody. So you look at the lesion of molluscum contagiosum, you see flesh-colored purple with central umbilication. And because of the fact that it affects the skin, it affects the keratinocyte, and this is the keratinocyte here. And you see the inclusion bodies, the molluscum inclusion bodies, they appear eosinophilic. So you see them staining pinkish or red. So once you see this in someone with this kind of lesion that I'm going to be showing us shortly, you think of molluscum contagiosum. I know that everybody knows, but just to show us again, molluscum contagiosum, so they would always have molluscum bodies on histology. So this is what it looks like. You can see the purple elevated with the central what's it called, umbilication. So yeah, I think that's that. So no problem. Let's go. So the next is a partner. That's the next H. A partner. So I have to double the H. A partner. A partner. The biggest example in a partner is hepatitis B. And I think that's the only example. Hepatitis B. A partner, hepatitis B. And we said it that the DNA is what? Partially double-stranded, and it is circular, just like the polyoma and the papilloma. They are circular, but HPV is partially double-stranded. It means that whenever HPV infects an hepatocyte, the first thing it's going to do is to complete it from a partial double-stranded to a complete double-stranded. That's the first thing it will do. So, and what can it cause? It causes acute or chronic hepatitis. It is not a retrovirus, but it has reverse transcriptase activity. Now, ideally, it is only retroviruses that have the ability to do reverse transcription. They are the only ones that have reverse transcriptase. Now, when we say reverse transcriptase, that means we are converting from what to what? Anybody?
RNA to
RNA to DNA.
mRNA to DNA.
Exactly. So converting from RNA to DNA. So what's it called? This guy has reverse transcriptase activity. And the reason why he's doing that is because if hepatitis B infects a liver cell, it's going to use the DNA polymerase of the liver cell to complete its genome to a complete, what's it called? A complete double-stranded DNA.
Double-stranded.
And the next thing is that it's going to use the same replicative machinery of the liver cell to move from this double-stranded DNA to RNA. Then it will use the machinery to move from the RNA to protein, to form protein to fight the person. But at the same time, this guy also needs to replicate now. So what is he going to do? All those DNA, those double-stranded DNA that have been converted to RNA, it will now start converting that RNA back to DNA by using its reverse transcriptase. That's it. And it will now be packaging them into the protein to form a complete new viral. So that's why the reverse transcriptase of hepatitis B is important. So moving on to the adeno, that is A. Adeno, A. So adeno can cause pharyngitis. We must know this. Adeno is the cause of sore throat. Adeno is the cause of pink eye. Very important. If you don't know anything about adeno, we know those two. It causes sore throat and it causes conjunctivitis. It can cause hemorrhagic cystitis, it can cause pneumonia, it can affect the GIT, causing gastroenteritis, and also the heart, causing myocarditis. So this guy can gain entry through the throat, and it can enter through the throat. It can enter through the throat and cause pharyngitis, then settle down to the lungs and cause pneumonia. And of course, the heart is just right in between the lungs, causing what? Myocarditis. And it can descend down to the GI, causing a gastroenteritis. And just beneath the GI, what do we have there? What do you have just beneath the GI? The what? The bladder.
The bladder.
And it affects the bladder, causing hemorrhagic cystitis. So that's a way we can look at the sequence of the adenovirus. And we have papilloma. An example of papilloma virus is human papilloma virus. It causes what? It causes cancer. And I want to say that the virulent high risk one includes serotype 16 and 18, very problematic guys, because cancer, and we talked about those cancer. What type of cancer are they going to cause? Anybody?
Oh, squamous cell.
Cervical.
Cervical and also
Cervical.
So cervical,
head and neck.
head and neck,
Head and neck, yes.
So squamous cell carcinoma, head and neck, blah blah. So the ones that cause what include serotype 1, 2, 6, and 11. What kind of cancer can 6 and 11 cause? Anybody?
To do with the oropharynx.
Just what?
What?
No.
It can also affect the oropharynx.
Yeah, conjure something.
This is high yield. They can ask you in your exam. Serotype 6 and 11 can cause papillomatosis, laryngeal papillomatosis. We should check our, what's it called? Our, I think it's under respiratory. If you're under respiratory.
Yes.
They can ask you, I'm serious.
Affect the vocal cords.
Yes. Tumor of the vocal cord, very common in babies. They'll just tell you that the child is having that something in the throat, and then, what is the organism? What is the serotype? They'll put 16 and 18 there. Some people are going to be picking 16 and 18. The answer is 6 or 11. Very high stuff. Don't joke with it. Never joke with it. Recurrent papillomatosis. Recurrent laryngeal papillomatosis is because I remember it's usually recurrent. So, yeah, 6 and 11. Polyoma example is the JC virus and the BK virus, the John Conyers virus and the BK virus. And this GC virus is responsible for causing progressive multifocal leukoencephalopathy. Anybody remembers a drug that predisposed to this PML?
Natalizumab.
Don't forget, in people with HIV, so they can have memory problems, they can have problems with vision, speech problems. That's JC virus for you. It's a polymer guy. BK virus also is very common in people that receive a renal transplant. So they can develop hematuria, AKI, hemorrhagic cystitis, very common in people that are immunosuppressed, BK virus. Then the parvo, we cannot go for exam and we don't know parvo. It is the smallest, and it is what? Single-stranded DNA. What does it cause? It causes aplastic crisis. Aplastic crisis. In people with sickle cell anemia, in children, it will cause a slap cheek appearance, right? Slap cheek rash in the cheek, And in adults, you might not see slap cheek. What are you going to see? You are going to see. They are going to tell you that the rash is, the what?
Severe arthralgia.
Yes, there could be arthralgia, but the rash, I'm talking about the rash now.
Rash along with fever.
They are going to have a lace
Fever, 5th day.
Lace-like reticular rash in the trunk. Once you see lace-like reticular rash in the trunk, think about parvovirus. And just like the doctor mentioned, they are going to be having some form of arthralgia, which looks like rheumatoid arthritis. So they can have arthralgia of the joint of the hands, fingers, in the rheumatoid arthritis-like distribution. So have a very high index of suspicion when you see somebody with rash having rheumatoid arthritis-like arthralgia, and they can also have the arthralgia in the knee too, and of course they will have the reticular lacy rash in the trunk, and in children it can affect the red blood cells, killing them off, the reticulocytes, killing them off, so causing a form of red cell aplasia, in what's it called, in fetus, it can also destroy their red cells, and that's going to lead to a form of high cardiac output failure. True or false? Yeah. So because of the high cardiac output failure, they can become hydrops. They die, in utero because of the hydrophytally. So B19 is a cause of hydrophytalis in children, in fetus, right? And it can cause the pure red cell aplasia too in in individuals because it damages the red cell precursors. And don't forget about the rash that we have talked about. Don't forget about the rheumatoid arthritis. Don't forget about the slap cheek distribution, and don't forget about the aplastic crisis in sickle cell disease. So the EPIs, these EPIs, we have about class 1 to 8, and okay, let's go for like let's go for like
Yes.
let's go for like 10 minutes break. I will come back for my 10 minutes time. Let's just come back in 10 minutes time.
Can we make it 15?
Yeah.
Can we make it 15?
10 minutes.
It seems the net not agree to that 10 minutes because we didn't hear you.
Yeah, we didn't hear you. 10 minutes is so small. It's
10 minutes is
Can we
okay.
make it 15?
We make it 15.
Or 1 hour.
Eh? Don't worry, we still go for a longer break. Let's come back in.
Take 30 minutes now or 20.
We need to finish it
20.
ASAP so everybody can go back to their
20 is
duties.
good.
So come back in 15
Can we
minutes.
take 20?
No, let us come back in 15 minutes, please.
Okay.
So we're starting with the herpes family, and the first is the herpes simplex virus type 1, and we know that this is a very common infection, and it's being transmitted by respiratory secretions of saliva, anything from the mouth or the nose, and it can cause some constellation of clinical findings, and these include gingival stomatitis. And what we are going to see in the exam is that they are going to say that the patient has some vesicular lesions in the gingiva and in the lips, the buccal mucosa. So once you are seeing vesicular lesions in the anterior aspect of the mouth, like in the lips, in the buccal mucosa, in the gingiva, just know that is gingival stomatitis for herpes simplex virus type 1. If we are seeing the same vesicles far behind in the posterior oropharynx, in the posterior aspect of the mouth, that is the one from Coxsackie. I don't know if we talked about it somewhere. I can't really remember. But Coxsackie virus type A is going to cause the hand and foot and mouth disease, and the oral ulcer is going to be posterior in the oropharynx. Why that of herpes is going to be anterior? So that's a way to know them. We have to know them. Very important, because the fact that it's vesicular doesn't mean that it's going to be strictly from herpes simplex. It could also be from Coxsackie type A. So it can cause this, and this can become healed, and the virus can hide and become latent in the trigeminal ganglia of the head. The trigeminal ganglia, that's where this herpes simplex virus type 1 hides. Now,
Dr. I'll come again, please. You say the oral ulcer in herpes, they will be in the posterior pharynx. Is that what you say?
In the posterior pharynx, yeah, for Coxsackie type A, Coxsackie type A virus.
Posterior. Okay.
For
Okay,
herpes simplex, it's going to be
it will be
anterior. So,
okay, thanks.
You're welcome. So it hides in this trigeminal ganglia. That's where it hides. But if it comes back, it doesn't come back to form gingival stomatitis. It reactivates to form herpes labialis, which is what we call a cold sores. So this is what it looks like. Just see this. This is cold sore. Herpes labialis, characteristic of the reactivated form of this herpes virus type 1. It can also cause temporal lobe encephalitis. You cannot go for an exam and you don't know that herpes virus type 1 can cause temporal lobe encephalitis. That is not acceptable. So, and what is the presentation? We just noticed that the person is going to be having altered mental status. Of course, there's an encephalitis, brain parenchyma. The person is going to be having seizures. And most importantly, aphasia, because we know that the area of speech is in the temporal lobe. So they're going to be having aphasia, they are going to be having seizures and altered mental status due to the temporal lobe encephalitis. So we see any form of enhancement in the temporal lobe, and we are thinking of encephalitis, just pick herpes simplex virus as the cause. So herpes simplex can cause esophagitis, and we know that the ulcer is going to appear what? Anybody remembers the appearance of herpes simplex esophagitis?
Punched out.
Punched out. And we said yesterday that herpes simplex virus is the commonest cause of what? Erythema multiforme. What else can cause erythema multiforme?
Mycoplasma pneumonia.
Mycoplasma pneumonia. Many people have forgotten. Only 1 or 2 persons. Don't let us forget all these things. Herpes simplex virus is the commonest cause of erythema multiforme. Mycoplasma pneumonia is another cause. Please don't let us forget. It is important. So, human herpes simplex virus type 2, this one follows sexual contact or perinatal transmission, during delivery and or across the placenta. So it can cause herpes genitalis or the what's it called, the neonatal herpes. So this herpes genitalis, you are just going to see a single or multiple ulcer, but it's going to be painful. So if the patient is having like painful ulcers, you should raise your suspicion for herpes genitalis. And because the neonate also, the baby passed through the birth canal, so they can also develop this neonatal form of herpes, in which the person is just going to be having numerous vesicular lesions in the skin, the eyes, the mouth. That should raise our suspicion for neonatal herpes. So this type 2 can actually hide in the sacral ganglion. So that is close to the perineum. So they hide in the sacral ganglion, while this one that occurs in the head hide in the trigeminal ganglion. So the viral meningitis is very common with HSV2, while HSV1 will cause encephalitis. Don't forget, HSV1 will cause encephalitis, HSV2 will cause meningitis. Viral meningitis, HSV2, encephalitis, HSV1. So moving on to the varicella zoster virus. So this one too can be transferred to respiratory secretion contact with somebody that is infected, and it can cause 2 conditions: varicella, which is chickenpox, in which the question is going to be telling us that the person is having some lesions, some rash that is that is at different evolutionary stage. So starting from the macule to the papule, vesicles to the bullae, and they are crusting, something like that. So once you have that, and it starts centrally, then move outwards. So start from the head, then the trunk, then moves to the extremities. That's varicella for you. Then it can resolve and hide, become latent in the dorsal root ganglion or the trigeminal ganglion, and it can reactivate later if there's any form of stress, immunosuppression, as the shingles, which you call the zoster. So let's see chickenpox. So this is part of the lesion for the chickenpox. Okay, this is the vesicular lesion for for the human herpes simplex virus type 2. We can see the vesicles in this baby's leg. So that's the neonatal form, and we can see different form of lesion, papules here and there. That's what we see for chickenpox. Although this one is not very classic, but we understand the idea. Just different evolutionary stages, and you see a lot of vesicles. And here now we can see that the vesicles are kind of grouped in a particular pattern. So once you see like a dermatomal distribution of the vesicles, we think of zoster. So it's not like different area like in chickenpox, but it's going to follow a particular dermatome, and that's classic for the what's it called, the zoster.
Shingles.
So the shingles, yes, thank you. So it can reactivate, just like I said, from the dorsal root ganglion or the trigeminal ganglion. And if it reactivates from the trigeminal ganglion, it can present as the herpes zoster ophthalmicus, in which you are just going to notice that the vesicular lesions are going to be affecting a part of the face. epizootal, ophthalmicus, and that is a very, very serious stuff. You have to step 2 now, give this guy high V cyclovir because the person is at high risk of losing that vision. So just like this, you see the vesicular lesion, affecting a particular segment of the V1 distribution of the trigeminal nerve. So that's epizootal ophthalmicus. Then moving on to the Epstein-Barr virus, human herpes virus type 4. The varicella is type 3, and the type 4 now is the Epstein-Barr virus, so we should not forget that. And we also said that it can follow respiratory secretion, saliva. So that's why it's called the kissing disease, because it can follow saliva exchange, and it's very common in young people. In fact, most of them will not be more than 20 years. You see like a 15-year-old, 20-year-old developing presentation of mononucleosis, just know that that's likely to come from Epstein-Barr. Epstein-Barr is not something we'll be diagnosing someone that is 50 years. I mean, the infectious mononucleosis is very common in teenage people. And what are the features? The fever, you cannot forget that. The hepatosplenomegaly, very, very important. This one is extremely important finding. The sore throat, which is the pharyngitis. The lymphadenopathy, which typically affect the posterior cervical node at the back. And once you are seeing that, just like I said earlier, once you are seeing fever, sore throat, hepatosplenomegaly. In fact, that's what I usually check when the questions come. Once I see fever and I see sore throat, I want to check, is there any hepatosplenomegaly? Is there any lymphadenopathy? Once you are getting hepatosplenomegaly, that is not the time to be thinking of bacterial, what's it called, pharyngitis again. So hepatosplenomegaly means it's likely to, be from Epstein-Barr virus causing the infectious mononucleosis. So we usually tell them to avoid contact sports. They can put this in the option and say avoid contact sports. Because you don't want to risk the spleen rupturing. Because if the skin is enlarged, that's a very high chance of rupturing. So don't forget that Epstein-Barr virus causes that, is a major cause of infectious mononucleosis, and it can also cause some lymphomas like the Burkitt lymphoma. It can cause nasopharyngeal carcinoma. Epstein-Barr virus is the cause of nasopharyngeal carcinoma. It can cause some lymphoproliferative disease, particularly in transplant patients. It's also a cause of primary CNS lymphoma. Hope you remember that primary CNS lymphoma, Epstein-Barr virus is a cause. Now, how does this Epstein-Barr virus infect the cells that it attacks, like the B cells, majorly? So it goes through the CD21. So it binds to the CD21 marker on the B cells and gain entry into them. And there's something we call the atypical lymphocytes. When somebody has an infection from Epstein-Barr virus, we typically have these atypical lymphocytes proliferating, and they look like this. So they are vacuolated. You see them having some vacuolations. Can we see these vacuolations? Can we see this?
Yes. Yeah.
Yeah. So that vacuolation, and you notice that the nucleus is going to be regular. So they are not looking like the normal T cells. So that is the atypical T cells. And they are produced because they are responding to try to eliminate these hyperproliferating B cells. So because Epstein-Barr comes in, enters through the CD21 on the B cells, enters the B cells to proliferate in the B cells, and the T cells start finding those B cells abnormal, and they start reacting to them to eliminate them. So what we are seeing here is not actually B cells, but reactive, atypical T cells. How do you make diagnosis of Epstein-Barr infectious mononucleosis? Just do your positive monospot testing, and that means that we're actually checking for the presence of the heterophile antibodies. So, and what happens? You just get the serum of somebody with Epstein-Barr virus, because we know that that person will have the heterophile antibody, and at the same time we mix it with red blood cell gotten from sheep or from horse. So if the person actually has Epstein-Barr virus infection, the heterophile antibody will mix and they will agglutinate with the horse or the sheep red blood cell, and there's going to be a reaction, and you can say that your monospot test is positive. But people with CMV infection, people with which other infection did we mention? CMV infection or toxoplasmosis. So they would have this kind of presentation, infectious mononucleosis presentation, but if you do your monospot test, it will be negative, high index of suspicion. some people make mistake and they try to use amoxicillin because of the sore throat. They think that this one gas now, group A strep, let us give amoxicillin, you're going to be okay. But at the end of the day, they can precipitate a maculopapular rash once they start that antibiotic. So high index of suspicion, once you have this kind of presentation and the person is started on amoxicillin and there's development of this rash, you know that the person is most likely having infectious mononucleosis. So moving on to cytomegalovirus. Cytomegalovirus can be transmitted through anything: congenital, blood, urine, saliva. Think of anything. Transplant, anything can transmit cytomegalovirus. And the first statement we have here is that it can cause infectious mononucleosis, but the monospot test will be negative. Don't forget, there's no way you can forget that. And this guy causes this infectious mononucleosis presentation in people that are immunocompetent, just like Toxo. But once they become immunocompromised, that's where CMV likes to flourish. So you have to think about the creep. So the C standing for the colitis. So CMV colitis. CMV colitis is one of the causes of bloody diarrhea. True or false? Anybody knows?
True.
Yes.
True.
CMV colitis is one of the causes of bloody diarrhea.
Mm.
It can cause retinitis. It can cause esophagitis. It can cause what's it called? The pneumonia. So I'm not sure we have. Okay, yeah. So pneumonia, esophagitis, retinitis, and colitis. And once we examine the eye under fundoscopy, we usually call it the pizza pie appearance. So you see the fluffy cotton wool exudate, surrounded by area of hemorrhage. That's what you call the pizza pie appearance of CMV colitis. Pizza pie appearance of fundoscopy, classic for what's it called for CMV. So I don't. Okay. So this one is not very, but just the area of this cotton wool spot with surrounding area of hemorrhage. Yeah, this one. So you just see cotton wool spot, this white thing surrounded by area of hemorrhage. So once you see white stuff with area of hemorrhage, it's like a pizza cut. So that's classic for CMV retinitis. So any cell that is infected by CMV would have a characteristic old high appearance, which is more like an intranuclear inclusion. So just like we have here, we see the whole high appearance here. So that's like intranuclear inclusion for CMV infection. So sometimes they hide in the mononuclear cell, like the monocytes and phagocytes. They hide there. So that's CMV for you. Moving to human herpes virus 6 and 8, very easy. They transmitted through saliva and they cause Roseola infantum. Don't forget, they cause the Roseola infantum. That's 6 and 8. And what do we need to know? They're usually common in children less than 2 years. And what you are going to see is just high fever. You notice that the temperature is very, very high for several days. Then that fever is usually very high that it provokes febrile seizures, febrile convulsion. Then after the fever subsides, the diffuse maculopapular rash will now start. So it starts from the trunk and spread to the extremity. So the way we usually teach this then is that we know that measles, and German measles. Who knows what is German measles? What is German measles called?
Rubiola.
No, it's not
Rubiola.
rubiola. Is it rubiola?
Rubiola.
Okay.
Sorry, rubiola.
Yeah, rubiola. Yeah.
So rubiola is rubella. Rubella. So rubella. So I don't know. I'm just asking you. So rubella.
No, rubella is different.
Yeah. Okay. I thought the person meant. Is the person trying to
Rubiola.
call it
Rubiola.
Can we call it rubiola too?
Oh,
rubiola.
Yeah.
Yes.
So we can call rubella rubiola too. Wow.
No, measles.
Oh, okay. Measles. Okay.
No, they are
Yes,
different.
another name for measles.
Another name for measles. Okay, yeah, that's true. Rubiola and rubella. So German measles is rubella. Measles is rubiola. So the way the rash starts for these two, it starts from the head, comes down, then to the then to the extremities. That's the usual way it starts. So, but this one starts from the trunk. It doesn't start from the head. So it's like the reverse. So it starts from the trunk and move to the head, then to the extremities. So, but the most important thing with respect to this brucella is the fact that it causes high fever, which provokes convulsion, seizures. It does the classic way they usually put it in the question. They don't change it. Then they will now tell us that the fever subsides and the rash develops and start from the trunk and move to the extremities. And the age is usually less than 2 years. So think of HHV6, and HHV7 too can be a less common cause of Brucella infantum. Then moving to the human herpes virus 8, that's the Kaposi sarcoma, sexual contact. So Kaposi sarcoma virus can cause a Kaposi sarcoma, which is a malignant neoplasm of the endothelial cell. So very common in people with HIV, people with transplant. And what we typically see is a dark volaceous plaques and the nodules, which represent the vascular proliferation. So this is what we see. We see the purplish nodules in the skin, and they can further tell us that when they biopsy these nodules, they are going to be seeing some lymphocytic infiltrate. So that's separated from what? Anybody knows from our dermatology?
Bacillary
From
angiomatosis that will have
angiomatosis.
neutrophilic
That will have
infiltrate.
neutrophilic infiltrate. So you can have the cutaneous form and you can have the visceral form. So the visceral form can appear in the in the lungs, and the person can have hemorrhage, bleeding in the lungs, and sorry about that. So 1 minute. Okay, so sorry about the interruption. That was my classmate. So so what was I saying? Yeah, so we can have these plaques, the nodules being formed in the lungs, and at the same time they can be formed in the GI. So in the lungs they can rupture and they could be hemoptysis, and in the GI too they can rupture there, and the person can have like hematemesis or hematochezia depending on how close it is to the mouth or the anus. So always have that at the back of your mind. So the HSV identification, how do we identify them? So we can do a PCR analysis of the skin to identify the human simplex virus, the herpes simplex virus type 1 and 2. We can do a PCR analysis to identify them, which is usually the test of choice. And for herpes encephalitis, so which strain is going to be causing herpes encephalitis, 1 or 2?
One.
Good job. Temporal lobe encephalitis, 1. Can do a CSF PCR to identify it. So we usually talk about this the TZAC test, but it's now outdated, which is good news. We have less one worry to deal with. So the TZAC test, this is what it's all about, and it is just more like a smear of an open vesicle. We just smear it off and examine it in the microscope, and you notice that there's going to be multinucleated giant cells. So it means that you have a lot of cells infected by this HSV fusing together, and they appear multinucleated like this. So that's just it. It's very common for HSV 1, 2, and varicella zoster. So once you see TZAC, multiple giant cells like this fused together, think about 1, 2, 3. HSV 1, HSV 2, or human herpes virus 3, which is varicella zoster. Don't worry about the cloudy stuff nobody's going to ask you. So what about the viruses and how they gain entry? CMV uses integrin or heparan sulfate to gain entry. Epstein-Barr virus using CD21 to gain entry. We have talked about this. B cells, right? CMV uses integrin to gain entry. HIV uses CD4, CCXR4, and CCR. I know that this is not strange to us. We've done that in immunology. Purple B19 uses the P antigen of the red cells. So that's why Purple B19 has high affinity for the red cells, because it can bind to the P antigen of the red cells, destroy the red cell precursors, lead to red cell aplasia, as well as hydrophytalis in the fetus. The rabies, they gain entry through a wound in the muzzle. So that's why it binds to the nicotinic acetylcholine receptor. Rabies virus binds to the nicotinic acetylcholine receptor. Very high yield, very important. Rhinovirus uses the ICAM. They gain entry through the ICAM. Rhinovirus gain entry through the ICAM. Rhinovirus gain entry through the ICAM. And all they cause is just common cold. That's all. SARS virus, which is COVID, enters through the acetylcholine converting enzyme 2 receptor. Anybody knows the condition where there's increased elaboration of acetylcholine converting enzyme? A disease.
Sarcoidosis.
Yeah.
Good job. So okay, let's see. Let's still move it a little. So we have the RNA now, the RNA virus, and the first one is Rio, and I talked about the fact that Rio is the largest RNA virus, and a very good example that is Rota, and it is a common cause of diarrhea in young children, particularly during the winter period. So during the winter period, there's a lot of rotavirus cases, and it can cause diarrhea in young children. Picona is another stuff under the RNA, and to remember the Picona virus, you have to remember the acronym PECH. So acronym PECH. the polio is a Picona, the echo is a Picona and can cause aseptic meningitis. Rhino is a Picona and it can cause common cold. Coxsackie is a Picona and it can cause aseptic meningitis, just like echo. It can cause angina. So that's the one I was talking about. That the Dr. Nancy, I was saying that the vesicles will be at the oropharynx. That's the angina of what's it called? Coxsackie type A. It can also cause hand, foot, and mouth disease. You see this angina in the mouth, you see these vesicles too in the hand, and you see it in the foot. That's hand, foot, and mouth disease, Coxsackie type A. Then the type B is classic for affecting the heart, causing pericarditis and myocarditis. Then we have the hepatitis A virus, which is another Picona, and it can cause acute viral hepatitis. So don't forget the patch. So the epi is just hepatitis E. So that's very simple. This is a big problem in pregnant women. Fulminant hepatitis. Callice, the queen of Callice. Norovirus is the queen of gastroenteritis. The Callice of gastroenteritis. And it is a cause of viral gastroenteritis, usually throughout the period. And it has overtaken rotavirus now. So norovirus is a serious problem. It's highly virulent, and we have the flavivirus. So whenever I see the word flavi, what comes to my mind is yellow. That's the next thing that comes to my mind. Flavi means yellow. So it makes sense for us to put hepatitis C virus in that class, and also to put yellow fever in that class. Then the wheezy, to remember the other ones, which includes yellow, the wheezy yellow. So dengue, West Nile, and Zika. So the D for dengue, the W for West Nile, and the Z for Zika virus. So the wheezy is for the flavivirus, the fly like the wheezy. So dengue, West Nile, Zika, very important. All of them here, they are important. You have to know them. The Toga virus, the Toga chikungunya, classic example. They have removed rubella and they have created the Mantona virus and they put rubella there. So retro, just true, human T leukotropic virus, which causes T cell leukemia and HIV/AIDS. And both of them, what is peculiar to this family is that they have the reverse transcriptase enzyme. That is what we need to know. The reverse transcriptase enzyme. That is what we need to know. Corona is corona. SARS, MERS, everything. Automyxo. What did we say about automyxo? They are what? They are
segmented.
Segmented.
And they don't undergo
what is there is that
reassortment.
exactly. And influenza virus is a very big example of automyxo. Cannot go for exam and we don't understand paramyxo. It is not acceptable. because we have three major classes under the paramyxo, which stands for the PRM. So the P for parainfluenza, which is a cause of croup. The RSV, respiratory syncytial virus, which is a cause of bronchiolitis. We cannot miss bronchiolitis. If you see feature of asthma in a baby, just go and pick bronchiolitis. Don't struggle. Examination. Please, let's mute our mic. Let's mute our mic. So, RSV virus causing bronchiolitis, in which the baby is wheezing. A baby of less than 2 years wheezing. Just go and pick your bronchiolitis and you move. So, what's it called? Measles and mumps. Yes.
When you're done, what's the second Z before we go too far? The second Z in the wheezy. One is Zika virus. What's the second?
No, the D for the dengue.
No, Z, the S, what they call it? Z.
No, I just put it there to just make sense. So, wheezy. It's just one Z. Zika, just one Z. One Z.
Okay.
So, yeah. So the M for measles in the PRM, the P for parainfluenza group, RSV, bronchiolitis, M for measles, and the last name for mumps. The four of them, they are the paramyxo. Then we have they've separated, they brought out RSV from paramyxo and they put it again in the pneumo. They're changing things now. So RSV, well, we don't care about the family. Just know RSV causes bronchiolitis. Rhabdo, you cannot forget rhabdo, rabies. And it uses what receptor? Anybody remembers?
Nicotinic
ACTH. So that's why it further makes sense for you to call it rhabdo. Skeletal muscle. Nicotinic ACTH, you find it in skeletal muscle. So philo, Ebola or Marburg hemorrhagic fever. Philo, arena, Lassa fever. Arena, Lassa fever. Fido, Ebola, Marburg. Bunya, I don't know. I don't understand anything in this Bunya. The only thing that makes sense is Santa. But it's not likely that we're going to be tested, on this Bunya. Very, very unlikely. Then the Delta is what? HDV, hepatitis D. That always require hepatitis B to replicate, is dependent on hepatitis B. So the PICONA, what's the acronym for PICONA? Anybody remembers?
Maybe the patch. The patch.
The patch. The patch. The patch for PICONA. So the P for the polio, the E for echo that cause aseptic meningitis, the R for rhino that cause common cold, the Coxsackie that can cause myocarditis, pericarditis if it's type B, and for type A that can cause aseptic meningitis, can cause what other stuff? Angina, as well as anal, foot, and mouth disease. Then of course the H that can cause hepatitis A, infection. So forget about what is there, we don't need it. Rhinovirus, common cold, that is it. It can be destroyed by the stomach acid, so it does not infect the GI tract, unlike other PICONA virus. So this one does not infect the GI tract because it's destroyed by the stomach acid. So it just infects the respiratory tract and cause common cold. Simple. Rota is the most important global cause of infantile gastroenteritis. Infantile, pay attention. Infantile gastroenteritis, and it is a family of the real. So it causes the diarrhea during what? The winter time. During what? The winter time. Very common in daycare and kindergarten because it is an infantile gastroenteritis. How does it do it? It causes villus destruction with atrophy, leading to reduced absorption of sodium and potassium. Anybody remembers another organ that we said that it blunts the villi, flattens the villi, and reduce? Anybody remember?
Celiac disease.
Any organism is an organism, not celiac. No.
Is it Cryptococcus?
No.
No, not Cryptococcus. Sorry. Cryptosporidium is what I wanted to say. Sorry.
No.
Is it Cryptosporidium?
No. We said that organism flattens the villi, limit absorption, enteropathogenic form, and it's common in babies.
Enteropathogenic babies, yeah.
Enteropathogenic form of what?
E. coli.
E. coli.
Enteropathogenic form of E. coli is a cause of pediatric
Okay.
diarrhea. You can see the way we are linking all those stuff. Once you are linking your stuff like that, you will not forget. There's no way you can forget, because you know that once I say this, I have to say this. Once I say that one, I have to say this one. So that's how you can, gather those information and tie them together. The CDC recommends routine vaccination, except this one is how you cannot forget. There's no way you can forget. Nobody is going to excuse us. We forget this. You cannot give routine vaccination as a live vaccine to someone that has a history of intussusception, because it can trigger a lead point, or someone with severe combined immunodeficiency. Hope we know the way somebody with SCID will present. Hope you know.
Yes.
Okay,
Yes.
very important stuff.
Yes.
Very, very important stuff. Influenza. So influenza, is this okay? So I think I have a question I skipped. I saw a question somewhere. Let me see what is here. Okay, a 2-year-old girl is brought from Pakistan 2 weeks ago to the emergency department because of one day history of progressive weakness of her left leg. 1 week ago, she had a 3-day episode of flu-like symptoms that resolved without treatment. She has not yet received any routine childhood vaccination. The deep tendon reflex is +1, okay, in the right lower extremity and absent in the left lower extremity. Analysis of the cerebrospinal fluid shows a leukocyte count of 38, which contains 68 lymphocytes, a protein of 49, and a glucose of 60. Which of the following is the most likely diagnosis?
Poliomyelitis.
Polio, yeah.
Polio.
So, why are we picking polio?
The
Vaccination history.
Yeah, vaccine.
lack of vaccination, the clinical
And
symptoms with the fact that
the
she had
reflexes
a
are reduced.
Yeah, so that's correct. And I did not even discuss polio with us. That's a very good job. So just to throw more light again, there's a weakness. You can see the weakness, the progressive weakness in the leg, and we can see the evidence of lymphocytic pleocytosis, which is what? The fact that the lymphocyte count is 38. Lymphocyte count of 38 in the CSF is high, and now 68% of them is now lymphocyte again. So that's the lymphocytic pleocytosis. And you can see the glucose is normal, it is 60. So that means it's a viral stuff. So viral stuff causing weakness, and like meningitis kind of thing, just pick your polio. So Coxsackie will not cause Coxsackie can cause this lab finding, but Coxsackie will not cause the weakness in the leg. So that's why Coxsackie is not correct. If it's herpes now, herpes can cause problem with the temporal lobe. So the patient might be having aphasia, altered sensorium, seizures, but we don't have that here. So that's how to rule them out. So moving on to influenza. Influenza is very important. It is an automyxovirus, very important. And what we just need to remember with respect to influenza is that it uses 2 agents. The first is emagglutinin, and the second is neuraminidase. Now, what does it do with the emagglutinin? It binds to the salicylic acid component of the respiratory epithelium. So if we have the respiratory epithelium this way, they usually have this salicylic acid, component. This is the salicylic acid, this S. So the influenza is going to come and it will bind to the salicylic acid component to gain entry into the respiratory tract. When it gains entry, and it starts replicating. So to release the viron from its replicating bodies, it needs an enzyme to be splitting those protein into different viron. It needs the neuraminidase. So without neuraminidase, there's no way it can replicate. So viral release, new progeny viral release by cleaving out those proteins like that so that they can be packaged to form new variants, you need neuraminidase. So that's why it needs both of them to gain entry and to replicate. And patients with influenza infection usually have a risk of superimposed bacterial infection. And we said Staph aureus is a common one, but strep pneumo can also be superimposed, or H. influenza. How do you treat? Supportive. But if you catch it within 48 hours, you can give what? A neuraminidase inhibitor. Not amagglutinin inhibitor, but a neuraminidase inhibitor, the one that prevents the release. An example of that is what? Oseltamivir or zanamivir. So the reason why we cap it for 48 hours is because if this guy is actually there to prevent viral release, it's believed that within 2 days or 48 hours, it will have replicated and it will have released what it wants to release. So that's why within 48 hours you can give this. But if it's past 48 hours, don't bother giving neuraminidase inhibitor because it will not work. So we talk about the reformulated vaccine. They just constitute this vaccine by predicting the kind of strain that's going to happen, that's likely going to happen within a season. So they formulate all those strains, they pack them together, and they administer it, but they don't really talk about it. So, but we talk about the killed viral vaccine, which is the one that is taking, I think, IM, and we talk about the intranasal one. Yeah, we talk about the intranasal one, which is the live attenuated one. So this killed one is taking IM, and the live attenuated one is taken intranasally. So make sure that you don't give someone that is having immunosuppression the live one. So this live one replicates in the nose. That's why we give it nasally. It doesn't replicate in the lung. The environment of the lung is too toxic for it to replicate. So just know that we have a killed viral vaccine of influenza, and we have the live attenuated one. And the mode of administration differs. The live is taken through the nose intranasally, while the killed is given higher. Brings us back to the genetic shift. We have talked about this shift, right? We said if you have infection of one cell by the two different segmented viruses, can you see the word segmented viruses? For example, influenza strain that has the ability to infect pig and the one that have the ability to infect human, it can undergo what? RNA segment reassortment, which dramatically changes the virus. It forms a different virus, causing a genetic shift, and it was a major global outbreak leading to what? Pandemics. It is as simple as that. So, because of the fact that influenza virus is a segmented RNA virus, it can undergo genetic shift or antigenic shift. And at the same time, it can also undergo genetic drift. But what is happening with respect to genetic drift is what I want to show us now. So if you look at virus A, if you look at virus A and B, they are interacting together and they are undergoing antigenic shift. And you are seeing that the new strain is getting the genome from virus A, which is a red, and the genome from virus B, which is this one. And you can see that the protein they are forming is containing a mix of both virus A and virus B, which is good. But in what's it called? In the genetic drift, you just have only one virus involved. It doesn't have to interact with another one. So only one virus is involved, virus A. And what happens to virus A? Virus A just suffers a small mutation in one of its genome. And it's going to replicate on that mutation, and that mutation might change some of this protein. So you can have a slight mutation in some of this protein. For example, if this protein is coding for the MR-glutinase or the neuraminidase, it can just change a little. So, but that change is not very serious because it's not going to change the entire genome. It's just only some parts that is going to change. So, and some of the immune system might still be able to react to it by attacking the protein constituents that are still normal. So in that situation, it's not going to cause something that is widespread, and it just leads to local seasonal outbreak like epidemic. So if you look at it, there's a random mutation in the MR-glutinine or neuraminidase gene, which causes minor changes in the MR-glutinine or the neuraminidase protein, leading to epidemic. So don't forget, it's only a mutation that causes a slight change in protein. But here you have a viral mixing, genomic mixing, totally changing the strain entirely. But this one is still the same strain. So just some slight mutation. So that shift or drift. So moving on to rubella. Rubella belongs to the family of the Mantona, and it's also known as the German measles. The constellation of signs includes the fever. So if the person has a fever, they have a post-auricular lymphadenopathy. You cannot forget that. Post-auricular, just behind the ears. Post-auricular lymphadenopathy. The people with infectious mononucleosis. What type of lymphadenopathy do they have? Anybody remembers?
Vical
Yes.
lymphadenopathy.
Yes.
Generalized lymphadenopathy.
So they have a posterior cervical lymphadenopathy, but these ones, they have a posterior auricular lymphadenopathy, and they can have arthralgia. You cannot forget fever, posterior auricular lymphadenopathy, arthralgia, and of course the rash, which we say is going to start from the head to the trunk and to spread to the extremities, as opposed to the rash of roseola that start from the trunk, move to the head and the extremities. So this one is centrifugal in that it starts from the head, move downwards to the trunk and the extremity. Very, very important. The rash is fine maculopapular. So it is a serious cause of congenital disease, congenital rubella, in which you get a classic triad of what? Sensorineural deafness, the cataract, and the PDA. Everybody knows this. It's common knowledge. And what is the congenital triad of or tetrad of Toxo? What's the acronym?
The
Chorioretinitis,
hydrocephalus,
hydrocephalus, associations.
So don't forget that this blueberry muffin appearance is classic for so many of them. It is not specific for anyone. So it's just kind of rash that develops due to dermal extramedullary hematopoiesis. So it happens in a lot of them. It's not only rubella. That's why we don't really talk about it. So moving on to the paramyxo, and we said that the acronym to remember the paramyxo is just to remember the P, the R, and the what, and the M. So the P standing for the para-influenza virus. So the para-influenza, the mumps, the measles, and what, RSV. Forget about man. Nobody's going to ask you about virus. The information is too much. So all of them can cause respiratory tract infection. All of them can cause bronchiolitis and pneumonia. But the one that is commonly implicated in bronchiolitis is what? The RSV. The RSV. The RSV. So all of them also contain the fusion protein. And what is the function of this fusion protein? It just allows, just like influenza is using hemagglutinin to bind to the salic acid. This ones express their fusion protein to fuse with the respiratory epithelial cell. So they fuse with the respiratory epithelial cell with their fusion protein, and they merge together to form like multinucleate giant cells. So we need to stop that from happening, particularly in preterm babies. So we give them palivizumab, and that is a monoclonal antibody against the F protein. So if we give this monoclonal antibody, it inhibits this F protein, and there's no way they can fuse with the respiratory epithelium to gain entry. So that means we are saving them from what? The risk of having bronchiolitis. Very important. So moving on to acute laryngotracheal bronchitis. So this is croup, and we said croup is caused by parainfluenza virus. Parainfluenza virus. Now, parainfluenza virus is just similar to influenza virus. Both of them, they express the protein, which is hemagglutinin, as well as the neuraminidase. The hemagglutinin and the neuraminidase. And we have said it that hemagglutinin is what is needed to bind to the salic acid to promote viral entry. So if they want to enter into the cell, they need the hemagglutinin. If they want to release their viron, they need to split them out by using the neuraminidase. And don't forget the neuraminidase inhibitors like the zanamivir and the oseltamivir. So oseltamivir and the zanamivir, very, very important. So what is a classic presentation of croup? The patient is going to present with bachy cough. They have hoarseness. They have inspiratory stridor, Very, very important. So when we see a child having backache, inspiratory stridor with hoarseness, you know that is likely to be a croup. And the pathophysiology is shared with the inflammatory response, which leads to narrowing of the upper trachea, as well as the subglottis, which is beneath it. So if you look at the nomenclature, laryngo, tracheo, bronchitis. So laryngo, that is the subglottis component, and the trachea. So they become narrow and stipple like this. You know, once you see the stipple sign on X-ray, you think about croup from para-influenza. So don't forget, it also expresses hemagglutinin and neuraminidase just like influenza. So so sorry about that. So sorry about that. So sorry about that. Yeah, can you hear me now? Can you hear me?
Yeah, we can. Yes.
So
Please,
sorry.
can you take the actual bronchial bronchitis again?
The what?
The acute laryngeal tracheal bronchitis. Can you take it again?
Yeah, so
Your voice breaks.
okay, so I said it can cause like it's caused by para-influenza virus. Reduce that for the noise and so sorry. So I said croup is caused by para-influenza virus, and both of them, just like influenza, it contains the hemagglutinin, which binds to the salicylic acid to enter into the cell, which is respiratory epithelial cell, and it also expresses the neuraminidase, which allows for release of the viral, after replication. And I said that the classic presentation for people with the para-influenza virus or croup infection is what? The presence of the backache cough. They have a backache cough. They have hoarseness of voice and inspiratory stridor. And they have all these things because it appears as if there's a narrowing of the airway due to the inflammation. There's a stippling of the airway due to the inflammation. And what part of the airway is affected? From the nomenclature, laryngotracheal bronchitis. So the larynx is narrowed, which is the subglottis area. The trachea is also narrowed. So they have narrowing of the upper trachea and the subglottis region. So giving them this stipple sign on the X-ray. Do you understand, doctor? Do you get it?
Yes.
Okay.
Thank you, sir.
So measles, which is also known as rubella, just like somebody told us. And we always remember the 4 C's of measles, which includes the cough, the coryza, the conjunctivitis, and the Koplik spot. Just always remember the C's of measles. Always remember the C's of measles. And the first thing is the cough, the coryza, which is more like the runny nose that they have. The runny nose, they have conjunctivitis in which their eyes become red. And you notice the Koplik spot. So the Koplik spot is more like the bright red spot in the buccal mucosa. So these are the Koplik spots. It appears 1 or 2 days later. So 1 or 2 days later after this Koplik spot, we start seeing the maculopapular rash, which starts just exactly like that of rubella, starting from the head, moving downwards to the trunk. Very important. And there used to be this lymphadenitis that is shared with measles. And what is part of the component of this lymphadenitis is the Wartin, Finike, Janssen. This is just academic stuff. We don't need it. It's because of fusion of the lymphocyte. You know that measles is a viral infection, and the lymphocyte will want to replicate to attack it. So they undergo fusion in the lymph nodes, and they form some germ cells that we call the Wartin, Finike. But nobody's going to ask us. Even this sequel, it's not very commonly tested, but it's good to know it. Academic stuff. The first is the SSP, which is subacute sclerosing panencephalitis, and it occurs after so many years after the measles, and they have some problems with their brain. They have some personality changes. They have dementia, autonomic dysfunction like urinary incontinence, erectile dysfunction, and later they can even die. So the subacute sclerosing panencephalitis is one of the complications of measles. They can have encephalitis themselves, and they can also have giant cell pneumonia, in which You're just going to be having normal cough and chest pain. And if you do your sputum analysis, you see evidence of fused macrophages, which are the giant cells. But the most important one that they did not say here is the pneumonia. Pneumonia is the most common complication. Normal pneumonia, not giant cell pneumonia. Normal pneumonia is the most common complication of measles, and it's even the most common cause of death, rather. That's what I mean. Sorry, not the most common complication of what? Most common cause of death, in children is pneumonia that follows measles infection. What do you have to administer in a child with measles? Once you make your diagnosis of measles in your exam, the next thing you should be looking for regards to treatment is what? Vitamin A supplementation. That is all you need. That is all you need, and you move. So that is very important to reduce the chance of death and sickness. So vitamin A, very, very important. So mumps can cause pumps. So POMP. So they have, of course, mumps is known for causing swelling of the parotid gland. So they can have a parotitis, and they can have otitis, which is inflammation of the testes. They can have the M, which is the aseptic meningitis, and it can cause pancreatitis. So pancreatitis is, important. Otitis is important. Parotitis too, they can be tested. And normally, the cases of mumps is reducing because everybody takes MMR vaccine. So the MMR works and protect against the mumps. But if anybody develops the mumps and it affects the testes, they can be sterile. It can cause sterility, especially if it occurs after puberty. But if somebody acquires mumps before puberty, because the testes are not well developed, then it does not cause sterility. So moving on to the chikungunya and the dengue virus. So the dengue virus is part of the Dewezi, and we said that once you see the word Dewezi, you want to remember the flavivirus, and the flavi means yellow. So that means we have yellow fever, hepatitis C, and the Dewezi. The Dewezi, the dengue, the W for the Western Nile, and the Z for the what? For the Zika. So it means that this guy is a flavivirus, and this guy here is a toga virus. So what you want to always remember with respect to chikungunya is that both chikungunya and dengue are transmitted by mosquito bites. So Aedes mosquito is causing a very serious problem. It can transmit both viruses. So beware of the Aedes mosquito. And chikungunya, what you are just looking out for is just this eye fever, your maculopapular rash, and your arthralgia with joint swelling. Once you are able to pick this, just go and pick chikungunya as your answer, because you are very confident that that's it. So eye fever, maculopapular rash, and arthralgia, classic for chikungunya, and they're usually having this joint swelling. So blood complication like blood complications like thrombocytopenia, leukopenia, and other hematologic manifestations is not very, very common. Like maybe anemia, it's not very common. What you usually have is the fever, the rash, and the arthralgia, which is actually with swelling. And how do you make a diagnosis? Because this is an RNA virus, you have to do your reverse transcription PCR. So that means that all RNA viruses are usually diagnosed through RT-PCR, meaning that you do your reverse transcription from RNA to DNA, then you polymerize that DNA through the PCR. That is just it. How do you treat? You can do a supportive treatment only. Or if it's very severe, you can give steroids and your DMARD. Because you remember that DMARD works for joint problems, like people with rheumatoid arthritis. So just give DMARD like chloroquine, sulfasalazine, methotrexate to treat the chronic arthritis. Minimize mosquito exposure. You're minimizing mosquito exposure, but because there's no vaccine currently. What about dengue? Dengue, commonly tested, they like it. You have to know that number one is the flavivirus. And what do you need to remember? You need to remember the fact that it can cause fever, just like this. It can cause maculopapular rash, just like chikungunya too. It can cause arthralgia too. Yeah, it can. But in addition to all these arthralgia, arthritis, the rash, and the fever, you are going to be seeing some extras, particularly joint and muscle pain, myalgia, arthralgia, and a retroorbital pain. So if you see a patient having retroorbital pain, fever, the maculopapular rash, myalgia, arthralgia, you want to consider the possibility of dengue. So that's dengue fever. But dengue fever proceeds as a spectrum. So some of them can have just this and have neutropenia too, or they can progress to have dengue hemorrhagic fever. Now, what you just need to know is that for somebody to develop dengue hemorrhagic fever, they must have been infected with another serotype. So the way it works is that if serotype A infects them, that serotype A is going to lead to production of a particular antibody, and the antibody is going to be in the serum. So the antibody stays here. So the way dengue works, I don't know why it's like that, but the way dengue works is that if serotype A causes this antibody to develop, by the time serotype B is coming, serotype B is going to find it very easy to enter. It's just going to bind straight to this antibody and use the antibody to gain entry, into different cells and be causing problems. So that's what we call the antibody-dependent enhancement of disease. It is very, very important if one is infected with a different serotype from the new serotype that is causing the infection. So, and that can cause what we call the dengue hemorrhagic fever. So it means that we are going to be having features of dengue fever, which includes the fever, the maculopapular rash, the retroorbital pain in the head, which can also be with the headache. So the headache and the retroorbital pain together, the fever, the maculopapular rash, the myalgia, the arthralgia, and is now having problems with bone marrow. So there's now bone marrow suppression. The patient is having neutropenia, the patient is having thrombocytopenia, and because of the thrombocytopenia, the patient is bleeding. So there's now hemorrhage. So we now have dengue hemorrhagic fever because of the thrombocytopenia, coupled with the high fever, coupled with the maculopapular rash, coupled with the headache and the retroorbital pain. So that's why it is stated here that once you are seeing thrombocytopenia or leukopenia from neutropenia here, don't think of chikungunya. Don't think of chikungunya. If you are seeing thrombocytopenia, leukopenia, hemorrhagic manifestation, just quickly go and pick your dengue and you move. So this hemorrhagic fever can now progress to cause shock, which is a dengue shock syndrome. It means that they are now bleeding. They are releasing inflammatory cytokines, which is destroying the endothelial vessels, endothelial lining of the cells, and you're having escape of plasma, from the circulation, leading to hemorrhagic shock at the end of the day. So because of the circulatory collapse. So once you have plasma leakage, there's going to be a dengue shock. So that's the one that kills them finally. So when somebody comes and is rushed in for dengue, you want to do a supportive treatment because they are in shock, they are losing blood, hemorrhagic fever. You want to immediately set up a blood transfusion or intravascular volume repression with IV fluids, anyone we have to correct the shock. But there's usually a recombinant vaccine for dengue, and that vaccine is coupled to yellow fever. So the component of the vaccine, includes part of yellow fever coupled to some part of dengue, as a recombinant live vaccine. But we don't have vaccine for chikungunya. So both of them, just make sure that you avoid Aedes mosquito. It is the cause of this problem. So Aedes mosquito did not stop at dengue and chikungunya. It still proceeded to cause yellow fever. And yellow fever is a flavivirus. And don't forget that the reservoir for yellow fever is usually the monkeys, or human beings themselves. So the way I look at yellow fever is that it has a primary target on the liver. It has a primary target on the hepatocytes. And because of the fact that it's a virus that causes a very bad infection, the fever is usually very high, just like chikungunya and dengue. High fever, and it enters the hepatocytes, causes some form of apoptosis of those hepatocytes, leading to jaundice. And it compromises the synthetic ability of those hepatocytes. They can no longer produce clotting, clotting parameters, platelets, the thrombocyto, like thrombopoietin and some of those, factors needed for clotting, so clotting factors and the likes. So that means that the person is going to be experiencing some bleeding tendencies, so leading to hemorrhage. And they typically bleed into the gastrointestinal tract, and that's why their vomiters is usually black. So once you are seeing somebody having high fever, having jaundice, having hemorrhage, you want to consider an hemorrhagic condition like yellow fever virus infestation. And they can even help us and tell us that this person has had a history of travel to a part of Africa, Ghana, Cameroon, Nigeria. That could increase our suspicion for yellow fever virus infestation. So the backache is very common because of the inflammatory stuff. So they can have backache due to myalgia of the muscles of the back. And when we do our liver biopsy, we identify the cancer body. So there are so many things that can cause cancer bodies. Yellow fever is one of them. And what do we mean by the word cancer bodies? All what we are just talking about is just the product of the apoptosis of this hepatocyte. So the apoptosis of the hepatocytes, they form eosinophilic apoptotic globules, which coagulate together in a way to form the cancer body. So they are eosinophilic apoptotic bodies. So they are product of apoptosis. That's the summary. And there's a live attenuated vaccine for yellow fever that will give travelers that are traveling through Africa and other endemic countries. So what about Zika? Zika is part of the DWISI.
Dr. Babu,
Yes.
just wanted to ask a question. Which did we say for both chikungunya and dengue virus? Which mosquito was it? Was it still the
Aedes.
80s?
Aedes,
Okay,
yes.
thanks.
Aedes. So Aedes did not stop. Aedes still did not stop at yellow fever. Aedes is still transmitting Zika. And Zika is also a flavi, part of the DWISI. And what you just need to remember for Zika is just CPR. And the C stands for the conjunctivitis. The P stands for pyrexia, which is a fever. And the R stands for the itchy rash that they develop. And I want to say it that Zika, just like Campylobacter jejuni infection, is one of those antecedent infection that can precipitate Guillain-Barré syndrome. Very, very important stuff. So it is very common in tropical and subtropical Africa, where you have a lot of waterfalls, because you have a lot of rainfalls that can create breeding sites for these mosquitoes. And, you offer supportive care, there's no treatment. So what do they present with? Don't forget CPR, the conjunctivitis, the fever, and of course, the itchy rash. Now, another thing about Zika is a congenital infection. And before I move to the congenital infection, I want to say it that in addition to the fact that Zika virus can be transmitted by mosquito bites, Zika is also sexually transmitted. You can see it in your exam. Very important. Zika is sexually transmitted. And it is also vertically transmitted. So that is why Zika virus can be a cause of congenital infection, because it can move from the mother to the baby. What do we need to remember with respect to congenital Zika syndrome? Number one, it can lead to miscarriage. And if it doesn't cause miscarriage, we have the congenital Zika syndrome that is characterized by MOM. The M for the microencephaly. Yeah. I want to mention here, because I did not say it, the congenital form of CMV, because CMV can cause a congenital stuff. The classic classification that we see in CMV infection of the brain is what? The periventricular classification. Just like we are seeing the diffuse intracranial classification in Toxo, we see the periventricular classification in CMV, and the classification we see in Zika is what? Subcortical. So if you are seeing a subcortical classification, meaning we are seeing classification in subcortical structures like basal ganglia, you know that what they are talking about is Zika. And you should always have the MOM at the back of your mind. The M standing for the microencephaly. But don't be deceived, because of the fact that there is a widespread cerebellar atrophy. The head will not still be enlarged, despite the fact that they have a ventriculomegaly. I'm not trying to confuse us. What I'm saying is that people with congenital Zika syndrome, they have a ventriculomegaly. Fine. But this infection, in a way, reduces the brain volume because there is cerebral atrophy. So because of that, even despite the ventriculomegaly, the head is still small. So they have microencephaly, they have some ocular abnormalities, and they have some motor symptoms like they can experience some spastic contractures and seizures. So once you see all these things together like that, just know that that is likely to be Zika, and this one usually gives it away quickly, the subcortical calcification. So it's an RNA virus. You have to do your RT-PCR analysis, or you do your serology. Simple.
Dr. Babawale, which one did you say atrophies?
The cerebellum, the cerebrum, the brain parenchyma.
Cerebellum or cerebrum?
Cerebrum, the brain parenchyma, the brain parenchyma.
Okay.
So rabies is part of the rhabdoviridae. The shape of rabies is bullet shape, and rabies forms some cytoplasmic inclusion that we call the Negri bodies. You find these Negri bodies in some particular area of the brain, like the Purkinje cells of the cerebellum and the hippocampal neurons. So, but what is it about rabies? Rabies is very common in people that get exposed to bites from. We used to think it's dogs, but unfortunately, if they put dog and bat in the option, please pick bat. Because in the United States, it's more from bats, from skunks, and from raccoon. So not from dogs, And when this bat, this raccoon, this skunk, they bite, the next thing is that they inoculate this virus into the wound from their saliva. And the next thing is that this guy is going to travel from the wound, is going to attach to the nicotinic acetylcholine receptor in the muscle and travel from the muscle to the nerve. We know that nerves supply muscles. So if this is a muscle here, if this is a muscle, this is M, this is a muscle, and this is a nerve here. So this is the NMJ junction. So what is going to happen is that once there's a bite, the rabies virus is going to travel like this and attach to this NMJ junction, like the nicotinic receptor here, and gain entry into the nerves. Then it will now use a dynein motor, protein. Remember the dynein motor harms from biochemistry?
Yeah.
True or false? Please, you
Yes.
should go and revise that stuff.
Mm-hmm. Which agreed.
Don't joke with that stuff. And it will move retrograde like that to the spinal cord. And when it gets to the spinal cord, it ascends upwards to the brain. And when it gets to the brain, that's when it now start causing the problems. And there's some classic presentation which I have here at the notes. Depending on the phase, the first phase, they are anxious, they start getting agitated, they are combative, and you can start getting confused and start hallucinating, and later they become photophobic, and they could present with features of fasciculation and spasm of the pharyngeal muscle. So they are fasciculating and the pharyngeal muscle are going spasm, particularly when they see the sight of water. We don't know why, but just mere sight of water, they're already undergoing spasm of the esophagus. So, and they find it very difficult to swallow. So, because of the fact that they cannot swallow saliva, and because of the fact that there's a form of autonomic dysfunction causing hypersalivation, so they have a lot of drooling of saliva from their mouth, So they are very, very scared of water. They are very scared of light, because all these two things can precipitate some pharyngeal spasm. They are photophobic, they are hydrophobic, they are agitated, and they are always hyper, hyper, like having fasciculations, increased muscle tone and reflexes, nurture rigidity. So with hypersalivation and increased sweating, hyperhidrosis. So everything in them is hyper. Just think about anything hyper. Somebody that is anxious, that is agitated, that is combative, that is not having hydrophobia, photophobia, spastic paralysis, or the person is having like increased spasm, increased muscle tone, increased reflex, that's having seizures, following like a bite of a skunk, that's likely to be rabies. So You want to debride and clean that wound, and it's part of the infection that you treat by doing passive and active immunity. Hepatitis B is something like that too, and you just give them both the killed vaccine, with the rabies immunoglobulin. So the rabies immunoglobulin is the one that is providing the passive immunity to neutralize any form of the virus that is still in the blood. And the vaccine is creating an active immunity in case of next time. So that's the post-exposure prophylaxis for rabies. So don't forget the dining that allows for traveling in the retrograde direction. Don't forget about the symptoms, which is important. And don't forget about the risk factors, which includes exposure to dog bites, bats, raccoon, and skunks. Very common. So Ebola.
You're saying you're sorry. Does it mean that dog bite don't cause rabies? Or are you saying just the most common?
Epidemiologically, in the US, bat, raccoon is common. So if it's in Africa, we can pick dogs.
Okay, because most of their dogs here are vaccinated and tamed. Their own dogs. Okay.
Yes. So, Philo, Ebola is an example, and Ebola can cause normal constitutional symptoms like flu-like symptoms, like just having like a form of runny nose, shivering, malaria, can cause diarrhea, vomiting, high fever. Then later, it starts showing itself, the hemorrhagic complications. So they can have like bleeding, hemorrhage from different orifices. It can even progress to DIC. And if you do your reverse transcriptase PCR, you can identify the organism. So most of the time, it comes if they get exposed to bodily secretions from people that already have this Ebola virus, or fomites like dead bodies, or infection from the bats or the apes, monkeys. So just like monkeys are also reservoir for which virus? Anybody
Yellow
knows?
fever.
Yellow fever.
Yeah.
Yellow fever.
Yellow fever.
So there are also risk factors for Ebola. So it's very common in healthcare workers because we are the first in contact, and you see somebody with diarrhea, vomiting, just think it's normal gastroenteritis, but you can attend to them unprotected and can get exposed to that infection. So the treatment is supportive care. If there's a need to transfuse, give IV fluids. There's no definitive care. So we have to vaccinate anybody that have had contact with anybody with Ebola, and we strictly isolate anybody that's already showing symptoms that's infected. We isolate them so that you don't transmit it to other people, and we ensure that we are well protected. We are using our PPEs to prevent the transmission. So that's that about Ebola. So I think we are going to stop here for today. This is such a long class. Hello?
I have a quick word on